To start.
All right, we're live.
Michael?
All righty. Michael, take it away. Dr. Lawton, take it away. I know you're ready to share your screen. Let's roll.
Yep. Hold on. I'm disabled from sharing.
We'll enable you right now, but I see a lot of people coming into the room.
Can the host enable me?
Just it.
Yes,
oh, there we go.
Yeah.
Okay.
There you go.
Oh, whoops. Actually, you know what? I don't need to share my screen. I just need to talk. Welcome everybody. This is a really exciting morning here. This is Mission Brain's, I believe it's our second webinar symposium on promoting global neurosurgery and partnership for health equity. And I've been tasked with just introducing this, and I just want to say a few brief comments and we'll launch this thing. You know, global neurosurgery has really become a hot topic. All of us in neurosurgery have spent a lot of time thinking about how we can bring our expertise and how we can bring neurosurgical care to people around the world who need it. And it's heartwarming to see so many people focusing on this topic and forming programs in their different departments. It's really become, I dare say, kind of a hot topic. So it just speaks to the importance of what we're all trying to do here. And Mission Brain has been at it now for over a decade. And I'm really proud of what this organization has become. You know, the progress is striking. When I think back to our first trip to Guadalajara to see Rodrigo and his team, you know, it was just a band of a couple of us with our bags packed with instruments, being stopped in the airport and searched and detained for hours trying to explain what we were doing, to now where, you know, we've got chapters around the world. We've been to multiple sites. We've got numerous really important partnerships with important people. And it's really exciting to see that progress over time. As I look to the future, I think that the pandemic, while it has stopped our trips and prevented us from traveling, it has opened up a lot of opportunities. The way that we connect with video and the way that we now do things like this webinar are really striking. And I think we can capitalize on this technology and take this effort, this Mission Brain campaign and this global neurosurgery campaign to a greater scale. And so it's really an exciting future that's ahead of us. So with that, I'm just say thank you for joining. Welcome to this. I can see in my panel here some of my dear friends who I've met over the years. It's a really great group of minds here that will be tackling these topics. And so with that, April, I'll turn it back to you and let you kick it off.
Thank you so much, Michael. Really appreciate you joining us today. And we have a lot of wonderful speakers and panelists joining us from all over the world. And I will not take a minute longer to have the opportunity to listen to them. Dr. Quinones is here with us, our president for Mission Brain. And we have our panelists who I'm going to introduce really quickly, and then we'll start with our first speaker. So I don't see Dr. George Jallo should be joining us hopefully in the next few minutes, but he is a board member of Mission Brain, has been working with us pretty much almost from the very beginning. He is a renowned pediatric neurosurgeon who specializes in minimally invasive keyhole surgery, brainstem and spinal cord tumors. He's a chief of neurosurgery and director for the Institute for Brain Protection Sciences at Johns Hopkins All Children's Hospital in Florida. Dr. Schwartz hopefully will be able to join us as well in the next few minutes, is David Norcell Barnes Endowed Professor of Minimally Invasive Neurosurgery and a Professor of Neurosurgery, Otolaryngology and Neuroscience at Weill Cornell Medical College at New York Presbyterian Hospital. Dr. Rodrigo Ramos Zuniga, who has been our very wonderful partner in Guadalajara, Mexico, who we worked with, as Michael mentioned, from the very beginning, and has been such an inspiration to us. Is a neurosurgeon, neuroscientist, and head of the Institute of Translational Neurosciences at the University of Guadalajara in Mexico. and Dr. Gerardo Gap Legaspi from the Philippines, who also has been quite inspirational in all the work he does at the Philippine General Hospital, is the director at the Philippine General Hospital and chief of neurosurgery at the University of the Philippines, PGH. And then Dr. Victor Garcia Navarro is a neurosurgeon, director of the Instituto Neurológico de Guadalajara, and for clinical science professors at Tec de Monterrey at the campus in Guadalajara, and graduated from the National Institute of Neurology and Neurosurgery, MDS, in Mexico City. His postgraduate epilepsy surgery fellowship was in the University of Washington in minimally invasive neurosurgery at Will Cornell Medical Center. Also joining us is Dr. Alexandra Diaz Alba, a neuro-oncologist from the Instituto Neurológico de Guadalajara, SC, Instituto Oncológico National Science, Clinical Sciences Tec de Monterrey campus at Guadalajara, and graduated from the National Institute of Neurology and Neurosurgery, MDS, in Mexico City. Her postgraduate fellowship in the Petit Salpêtrière Hospital in Paris, France, and currently head of the Department of Neuro-Oncology at the Instituto Neurológico at Guadalajara. Dr. Ronnie Baticulon is a pediatric neurosurgeon at the Philippine General Hospital and professor in anatomy at the University of the Philippines College of Medicine. He completed his pediatric neurosurgery fellowship at the Royal Children's Hospital in Melbourne, Australia, and also trained in ETV CPC at the Cure Children's Hospital in Mbale, Uganda. He's a member of the WFNS Young Neurosurgeons Committee. Welcome, everyone, and thank you so much for spending your time. I know a lot of you are coming from all different time zones, those coming from the time zone late at night. We really appreciate all of you coming here. I know you're all very busy. We are going to go ahead and proceed to our first speaker, who will be introduced by one of our team members. So take it away.
And just to mention, April, that Dr. Jallo is finished in the operating room. He had an emergency case, so he'll join us soon. So I heard from him already, just to make sure that people know.
Fantastic. Okay.
All right. Good morning, everyone. Thanks for joining us this morning. It's my pleasure to introduce our first speaker, Dr. Ernest Barthélemy. So Dr. Ernest Barthélemy is now completing a fellowship in neurotrauma at the University of California, San Francisco. He is originally from New York and completed both medical school and residency at the Icahn School of Medicine of Mount Sinai. He was also the Paul Farmer Global Surgery Research Fellow at Harvard, where he completed his master's in public health. He is also the co-founder and president of the Society of Haitian Neuroscientists, and that's an organization with members of 5 continents that aims to advance neurological care and mental health in all Haitian communities. He also sits on the Global Health Task Force for the International League Against Epilepsy of North America and is a member of the Young Neurosurgeons Forums of the World Federation of Neurosurgical Societies. So please take it away, Dr. Barthélemy.
Thank you. Thank you for that very generous introduction, and I'm excited to be here with all of you, and particularly to join my mentor, Dr. Kee Park, on the same panel. That's a sign to me that I'm doing at least a few things correctly. So with that, let me go ahead and share my screen with you. Okay. All right. Is that appearing clearly? Great.
It looks great, Ernest. Looks beautiful.
Okay, thank you. Thank you so much. Okay, so Uncharted Waters, Navigating Global Neurosurgery. This title is inspired by distinct versions of this talk that I prepared formerly for medical students. So there are major changes to this presentation, but the name still captures what I feel has been and continues to be my path in this emerging neurosurgical subspecialty, which is one of having been a trainee for most of it thus far, I'm really, sort of at the entering the springtime of my career. And yet, given that the field itself is also so young, I do often have people approaching me for questions about how to do things that I'm sort of just figuring out or haven't even done yet. And so it does strike me as an experience in navigation, or trailblazing, if you will. I have no disclosures for this talk. And so, in the words of one of my childhood heroes, this is some advice I'll pass along for this. And I'll probably have more questions than answers. So excited to be in the conversation with you. So in the way of overview, first, I'll just look at a couple of terms I feel are critical to our work in the global neurosurgery space, and then move into the matter of a global neurosurgery training. I'll then transition from there into neurosurgery in Haiti and the work I've specifically been doing there, and finish with the conversation that I believe inspired the invitation I received to participate in this webinar. So I am Haitian American. Both of my parents were born in Haiti, and I was born in the United States and raised in the US. And so that bicultural experience absolutely informs every step I've taken in my career as a rising global neurosurgeon. And so I'll start with this important concept on the website for the Center for Health Equity and Surgery and Anesthesia at UCSF, which has a very memorable web address that you can go to here. But this concept of local health equity being global health equity, I think, is key. And I would suggest one recurring theme here is that this is not only metaphorically the case, it is actually the case that global neurosurgery is a field that is highly pertinent to us wherever we are, including our own countries. And this gets across in an article I like to go to define global health. Copeland and colleagues in 2009 in The Lancet discussed the fact that global health issues are issues that not only cross international borders, but concern many countries, are affected by transnational determinants of health, and really are global in their scope and not just global by location. And of course, as many of us are aware, epidemic infectious diseases are clearly global. And we're in the midst of a pandemic that has reminded us why it's important for us to care about the health of people in other countries. But global health should obviously include not only epidemic infectious diseases, so injury prevention, migrant worker health, and the migration of health workers is also important. So, if you're here in the United States and you're finding out that a local farm is abusing Mexican migrant workers, that should matter to you as a neurosurgeon, and not only because one of them could be your neurosurgeon someday, or if you're finding that Haitian asylum seekers are suffering from abuse at the hands of your government here in the United States, and they're using a very controversial legislation, Title 42, to certainly adversely impact their health and not only infringe on their human and civil rights, you should care about that, not only because one of these people or the children of one of these people could be your neurosurgeon someday. So I would argue this, these are issues, and we're constantly reminded in this country, which is a country built by immigrants, that the questions and concerns of global health and global neurosurgery are highly relevant. Ironically, the one group in the United States that does not constitute the immigrants or descendants of immigrants is a group that suffers tremendous health disparity. So what is health equity? And when we speak about health equity, which I would say is a vital and core value of global neurosurgery, really we're talking about social justice in health. So the term health disparities is a way we use to measure how well we're doing in in our goal to achieve this social justice. So to the extent that we're able to reduce health disparities in neurosurgery and every other aspect of healthcare, we can say with evidence that we're doing that we are moving towards this ideal of health equity. And moving towards greater health equity is achieved by selectively improving the health of those who are economically and socially disadvantaged, not by a worsening of the health of those in advantaged groups. And I think that's also an important perspective to share, particularly among groups, politically motivated or otherwise, who may feel threatened by the prospect of health equity and what that might require of a society. So health disparities, I'll use this as my transition to Haiti. Now, in the United States, and I would say my sense is that beyond the borders of the United States, globally, we've all learned about this time of reckoning that the United States finds itself in, having dealt with the George Floyd catastrophe and other revelations, which turned out to be really, unfortunately, not so extraordinary in terms of life in the US, but hidden for the most part, I would say, from the eyes of many Americans until a video and social media exposed what was really happening. And that and other concerns around racism in this country have reopened a conversation about where we are and what is the mismatch between at least what the values of people in the United States are, what we say we believe in, according to our founding documents, etc., and the behavior that is a mismatch for those values. And so, the idea and really the lesson of history from the transatlantic slave trade, a topic that can be very, very uncomfortable to talk about, and that many people would prefer to forget and say, "Oh, this happened so many hundreds of years ago. What importance does that have?" Well, I would say that as physicians, we have an immediate appreciation for how critically important the history of the present illness is. Because if we don't understand the history, we have absolutely no context for appreciating what the diagnosis in front of us looks like and whether or not it's treatable surgically, medically, or otherwise. And so I'll just point out from this article that we published in 2019, where we describe the current state of neurosurgery in Haiti, Cuba and Haiti. And I won't go any further. I didn't include the US in this. I was trying to benchmark a little bit geographically. So these are countries that surround Haiti. Now, what's really fascinating about Cuba is besides what we know more recently, political questions about Cuba, there's something very interesting about the history. Haiti was the first independent Black, if you will, nation on the planet, actually. The first nation to be comprised of formerly enslaved African people who led a successful revolution against the French. This had many, many repercussions throughout the Western Hemisphere and the world. This happened in 1804. In the United States, one repercussion, it immediately doubled the size of the United States because the United States gained a very cheap territory that today is essentially the whole Midwest, okay, which we called the Louisiana Purchase at that time because Napoleon was run bankrupt by this revolution. And so, immediate geographic expansion, et cetera. But consider that a country of formerly enslaved African people liberates themselves in 1804, Cuba and all of these other surrounding territories, which also had slavery-based economies. Cuba liberated itself from slavery or abolished slavery in 1886. So from 1804 to 1886, you're talking about 82 years of history that represent what the normal state was in the hemisphere. And that has absolutely strong influences on the geopolitical context in which Haiti evolves. And then France, after having lost this cash cow that Haiti really was for the French Empire, levied a reparations debt on Haiti that Haiti took almost 150 years to pay off, and finally paid off in the mid-1900s, which totally crippled the Haitian economy. So I'll stop there, but all of this to say that when you look at a neurosurgeon per 100,000 population density of a country, of 12 million people, and there are 4 neurosurgeons for those people, and then you compare it to Cuba, which has a neurosurgeon per 100,000 population density that's much closer to the US, which is about 1.5 in the US. There's a lot more to this than questions of, are you a communist country or are you a democratic country, etc. Okay, and so in this article, you can look at some of the other aspects of the neurosurgical health disparities in Haiti. So with that, I'll move into this question, which I think is very important. It's very real for me because I'm looking for a job right now. And I've been interviewing and having interesting conversations with department chairs. And I will sometimes get this question turned back towards me. How do I go about creating a global neurosurgery program in my department, right? And I would say, well, neurosurgeons obviously, and I say this very, very authentically, are a brilliant group of people. It's one of the reasons I went into this field. It's the resourcefulness and brilliance of neurosurgeons is something I saw would really nourish my career for a lifetime. And that's why I went into this field. So I would say it's even more important to be clear why you should go about doing this if you run a department. Because I think if you're committed to the why, the how seems to just follow in this field. And I would propose that there are some reasons. Now, particularly in the United States, there's this whole question of how are we staying afloat? For better or for worse, in the United States, we have a highly commodified system of medicine. And there is a profit motive that is often imposed on us, regardless of what our participation may be in that. And that is one of many complicating factors of healthcare, which is a field with many, many market failures economically, okay? And yet it's something we have to contend with. So when we're looking at bringing a new program into a department, certainly there's gonna be a question about what are the dollars and cents of this, right? What does the value equation look like for this program? While certainly there's a tremendous opportunity in resident education, and we could have several webinars just about this aspect of it, but it is a huge opportunity for creating stronger neurosurgeons. There is certainly an opportunity in terms of publicity and corporate social responsibility. Particularly as I said at the beginning, when this global neurosurgery program becomes an opportunity to look not only at what's happening outside of the nation's borders, but what's happening to the communities in one's own city, state, nation that suffer similar challenges as people from the most impoverished regions of the planet. There is an opportunity in terms of social impact locally and globally. I touched a little bit on the many immigrant communities who can be positively impacted by a global neurosurgery program. Huge opportunities in terms of research collaborations. And there certainly is an opportunity in terms of social innovation and business opportunities if one is willing to step into that prism and say, well, what does a win-win situation really look like here as we're trying to fill this massive gap in healthcare? As was mentioned at the very beginning, I was delighted when Dr. Lawton introduced global neurosurgery as a hot topic and hot field. I believe this will continue. And frankly, I think we will see in our lifetime a moment when not having a global neurosurgery program in your department will actually hurt you in your competitiveness as a program. Okay, so once you've established, and I'm sure there are many other reasons to do this, but those are some thoughts. Why one should do this, there's the question of how. And I think it's sort of two sides of the same coin, whether you're a training resident or medical student or even fellow or neurosurgeon early in one's career or in the autumn of one's career. And you're looking at, well, how do I transition into being an academic global neurosurgeon? I think the other side of the same coin for department faculty, leadership, and people who participate in creating transformative enterprises like Mission Brain is, well, what do we do to empower trainees to be academic global neurosurgeons? I think this is another important question. So briefly, I'm sure it's clear at this point that my focus here really is primarily on neurosurgeons, neurosurgical trainees and departments in the United States, a high-income country context. And so, what I'm putting forth is really directed that way. I do want to acknowledge that there is a vast and growing literature that also addresses neurosurgeons and neurosurgical trainees in low and middle income countries. And so I've put up a few of these articles here just to give you a glimpse. If you're not yet familiar with this literature, here are some great articles put out both by the Young Neurosurgeons Forum of the WFNS, which I was fortunate enough to recently be named a co-chair of a couple of weeks ago, and other luminaries and rising stars in this field. Here are a few other articles. Okay, but that's not what this talk is about. This talk is about what we can do in a high-income country context like the US. And Dr. Park and I worked with Walt Johnson during my time as a Paul Farmer Global Surgery Research Fellow on a perspective looking at what can neurosurgeons do to express our leadership and exercise the kind of impact we can have in the space of the global transformation to which the international community committed itself with the Sustainable Development Goals in 2015. And so in the way forward portion of that piece, we recommended training in 4 different domains as a strong starting point. Study, practice, research, and advocacy. And some of the things we highlighted in terms of studying, obtaining further training in social sciences and public health, learning the language of global surgery. There certainly are some foundational documents and articles that one should familiarize themselves with and start picking up what this new language is. In terms of practice, focusing on capacity building and neurosurgical education. In terms of research, striving to understand local neurosurgical epidemiology, as well as the social determinants of neurosurgical disease. And then certainly developing the case for emergency and essential neurosurgical care as a vital and indispensable component of universal healthcare. So we followed this up, Jacob Leopard and I and a few other colleagues followed this up with an article that targeted our own peers when we were all residents. We got a little bit more into this, looking at what are the opportunities to engage clinically, looking at how we might start thinking about engaging scientifically in the global neurosurgery space. And then what are the questions in terms of policy and advocacy that are relevant to our field and in which we could start to exercise some leadership as rising global neurosurgeons. So Raleigh and colleagues later published this interesting survey piece that started to look at, so what is happening in the United States right now in terms of global neurosurgery training programs? And this article, based on a response of 34 participants in this survey, found that among those participants, still a relative minority of programs had what they considered to be a high level of global neurosurgery engagement. On the flip side, 18 programs with low level and 14 programs with moderate level engagement, I saw as a huge step forward, because a decade ago, I think we would have frankly had zeros or just very low numbers across the board. So this is moving. And they asked some other pertinent questions that I think are worth thinking about in terms of, well, what should we do to design and really launch a global neurosurgery program in our department. So they asked whether the residency program offered a designated track for international health. Is there a core curriculum, or are there didactics focused on global or community health in resource-constrained settings? Are there rotations in resource-constrained, rural, or marginalized settings for at least 2 weeks? By the way, anyone working in a county hospital in the United States would certainly have that kind of a rotation. And I think that became clear to me, having spent time in county hospitals now both on the East Coast and on the West Coast. I was really struck by how similar the experience of the undocumented, the uninsured, and really marginalized communities are in under-resourced hospitals in the United States. Are there continuity clinics in marginalized resource-constrained settings? Are there periodic lectures dedicated to global neurosurgery? Are residents offered supplementary reading material on global neurosurgery? What are the opportunities, if any, for conferences in global health and global neurosurgery? And finally, are there any funding and opportunities for research programs in global neurosurgery in these programs? Okay, so all helpful things to start looking at as you design and prepare the launch of your department or institution's global neurosurgery program. So I'll move into this component that looks further at what I did in Haiti. And I started a lot of this when I was a Paul Farmer Fellow with Dr. Park. And so what's notable about this picture is that at the time these pictures were taken, this was 100% of Haiti's neurosurgical workforce. So I'm with Patrick Valsin over on the left side of the screen, Bernard Pierre on the right side of the screen, and these two sort of flanking the sides, Patrick Valsin and Bernard Pierre, are both neurosurgeons who received general surgery training in Haiti and then went to French Caribbean territories to get their neurosurgical fellowship training thereafter and came back to practice. And then in the middle, I'm pictured with the only two neurosurgeons in Haiti for decades who were trained in full-scale neurosurgery residency programs the way we're familiar with them in France. Alix Elie, who's the senior neurosurgeon, no longer practicing, but still around in the country. He's in the pink shirt there. He currently runs the epilepsy clinic of Port-au-Prince in Haiti. And Ariel Henry, who is standing to my left side in the grayish blue shirt, who's currently quite busy as the Prime Minister of Haiti, and so is not finding as much time to operate. But prior to that, was really the source of the top level neurosurgical care, and actually continues to be sort of the pillar of neurosurgical care in Haiti. And so despite the great contribution and very challenging contribution he's making in the political space, neurosurgery does suffer now with Ariel having his attention where it is. But when I met these gentlemen during my fellowship, I proposed to them the idea of building a community in Haiti around advancing clinical neurosciences. And they both told me that actually they were, and these are the two gentlemen in the middle I'm referring to, Alix and Ariel, they both told me that actually Haiti had such an organization. It was founded in 1993. It had been dormant for 20 some odd years. And there were a variety of reasons why that was the case. But they asked me whether I thought we could bring it back. And I said, absolutely. Why don't we work on that? And so la Fondation Haïtienne pour le développement de la neurologie et de la neurochirurgie, which they abbreviate as FADNEC, is the organization that we brought back. Alix Elie was the founding president of that organization. Ariel, also a founding member. Ariel became the new president when we brought it back in 2018. And then he nominated me vice president of the organization. And then we brought together these neurosurgeons and the few neurologists in the country and planned a first ever international conference that we started to design with the partnership of the WFNS. Unfortunately, the political situation in Haiti prevented us from being able to move forward with those plans. And so that conference has been indefinitely postponed. And it was around that time I started wondering about this interesting mismatch between this terribly low neurosurgical workforce density in Haiti, and the knowledge that I belong to a diaspora that I knew was incredibly successful in all fields outside of Haiti. And I started wondering, well, how many neurosurgeons are there, of Haitian descent outside of Haiti? And how about the other neuroscience, other neurosciences for that matter? And that's where this idea for the Society of Haitian Neuroscientists came from. And I actually got Arik Celi's and Ariel Henry's blessing to start building the society, just because that's the kind of thing you do culturally. And they actually thought this made great sense, and that when Haiti was in a more stable place, that a society like this could help us to very rapidly advance the objectives of La FADNEC. And so we put it together, and much of this happened during COVID. And at this time, we have about 80 members in the countries listed here. I said 5, but there are actually 6 countries. So USA, Canada, Haiti, Colombia, France, and we recently had a speech and language pathologist join us from Qatar. And all members are of Haitian ethnic and cultural heritage. All members are currently practicing or training in this list of neurosciences here. Okay, and this is our website. So the mission of SHN is to promote the basic clinical and translational neurosciences in Haiti by the creation of the conditions necessary for their advancement, to enhance and advocate for neurological and the mental health of all Haitian communities, and to foster collaborations between Haitian neuroscientists. So this picture just shows a sampling of our membership involved in various aspects of the leadership of the organization here. So to date, we're a young organization. We've been around barely a couple of years. Our lawyer is actually looking at our bylaws now, so that young. But we did establish ourselves and grow pretty quickly, and we were certainly helped by the telehealth and social media waves that I think really exploded during the COVID pandemic. So that actually facilitated our ability to reach out very far, very quickly to build the organization. We have about a year and change of educational and training service to the Hôpital Universitaire de Mirbalais in Haiti, which has a neurology training program that was delighted to have our society support them with weekly case conferences and lectures virtually since we were founded. We have also built and are currently running a mental health platform clinically and research-wise. Much of this was inspired by the earthquake of August 14th and the recognition that there was a lot of existing psychological and mental health concern from the prior earthquake and prior political context. And now we had this second hit, if you will, on top of it. And so both within Haiti and throughout Haitian communities outside of Haiti, we recognize the need for mental health support. And we have a number of psychologists and psychiatrists in our membership who are very interested in taking this on. So we're working on that. And we've also released some public statements relating to some of the recent crises that Haiti has been dealing with. So young and growing, sort of like global neurosurgery. What are we, November? We're November. So in September, I visited Haiti in this post second earthquake space to connect with one of my colleagues who is one of the new neurosurgeons in Haiti, Yudi Lafortune. Yudi Lafortune is a general surgeon who's by training, who's trained in one of the programs in the north of Haiti, who was fortunate enough to be selected and to complete a neurosurgery fellowship program that was designed in partnership with the University of Miami, Project Medishare, and Haiti's Ministry of Health. He's also a direct protege of Ariel Henry, who's the current prime minister. And he asked me to come by, support him with some cases he wouldn't normally do independently without having Ariel Henry there with him. And so I came through, and this was through Project Medishare, a great organization with several decades of significant service to Haiti in the neurosurgery space and otherwise. And they do have probably the best resources, no, certainly the best resources available in the country as far as neurosurgery is concerned. And we did some hydrocephalus cases together, as well as some spine surgery cases. And this trip, what was significant about it was not just the cases that Yudi felt was very useful to his continued training that I got to do with him, but some friends from Mission Brain I was fortunate enough to make when I came out here to San Francisco, gave us some critical supplies that he needed. And this young kid here at the bottom right benefited from a shunt that Mission Brain provided us with, that I brought with me, and we were able to treat his severe hydrocephalus. We brought a microscope drape that enabled us to make use of a microscope for one of our spine cases. And then we had a traumatic CSF leak from a young woman with a devastating thoracic spinal cord injury. At the end of the case, Mission Brain gave us some Duraceal that we were able to use to finish up that traumatic dural repair. And so this was really timely, a timely and fortunate silver lining in an otherwise very, very difficult situation in Haiti. So currently, the Society of Haitian Neuroscientists is working with Zami La Santé, that's Partners in Health's sister organization. They directly invited us to help them design and develop their neurosurgical system over the next few years. So we're in a very early stage of doing that. Much of that is happening remotely for now, given the current political context. But we know this will be a multi-year engagement. And the question is, who else will we partner with to make this happen? And so, I think there's a lot of prospects for people who can help us to make this happen. So finally, in terms of how can we advance health equity in global neurosurgery from the perspective of enterprises like Mission Brain, global neurosurgery programs and partners. So I think step one is listening and relationship building. And I think this point cannot be over emphasized. I like to refer to Paul Farmer's Staff, Stuff, Space, and Systems framework, which was very much inspired by his learning and Partners in Health's learning about what made for an effective response to the Ebola crisis. There was a lot of discovery about what it takes to deliver care effectively. So I think this can be a useful framework to think about. So resource transfer in the way of money, supplies, human resources, different possibilities in terms of partnership, making sure that we're working on things that are sustainable, and sort of plugging these into this framework and looking at what's missing. But much of this comes through the relationship building and really listening effectively to our partners for what they need and how we can best be of service in these bidirectional partnerships. So finally, I'll recommend this book. I was fortunate enough to be invited to review for the Lancet, One by One. I found this to be an absolutely beautiful anecdote about the need for neurosurgical care. And it wasn't obviously that until you got in and started reading. That's what this book is. It's actually a journey through a neurologist's work in Haiti, sort of seeing firsthand what the unmet need for neurosurgical care looked like. And I enjoyed reviewing it and highly recommend this book. Okay, so with that, thank you for your attention. And this is my wife and daughter to the left. So the girls are on the left, the boys are on the right, and my kids there at the bottom together. I'm happy to take your questions now. Thank you.
Beautiful and inspirational talk, Ernest. Absolutely. I don't know if you weren't able to keep track of all the comments and that are put in the chat that we are also saving. Actually, I took a couple of questions, and I'm going to open it. We have a few minutes, April, for some questions before our next speaker. Is that okay? Did
Absolutely.
I see you nodding? Yes, absolutely. So I took a few things, something that just stayed with me, and Kee also commented, and Dr. Ramos and George and several people, is something that you said that is quite profound. Programs that are not going global will not be able to deliver complete global care. I mean, I just paraphrase a little bit. I'm just trying to figure out things that people can take, you know, and as part of the message is always, and that we can actually, the other message that I got from you is that we can partner. None of us, and Kee and I had another chat right here, none of us can do these things alone. We have to figure out how do we build not only physical bridges, personal, but also virtual, just like what we're doing right now. We got to learn how to use technology, you know, how to use innovation, how to use inventions. As neurosurgeons, as surgeons, we are innovators. We have to invent better things to be able to provide better surgery around the world and not at the cost that we have right now, because otherwise it's even prohibitive in developing countries like ourselves. The other message that I got is the steps. And the one word that comes back with me is listen. Listen to the needs of the world, listen to the needs of our countries, listen to the needs of our patients. So I put those in perspective. And then I'm gonna ask, you know, your mentor, you know, Dr. Park, to make a few comments and a few questions, maybe. That if you guys also help me monitor the chat for questions, I'll really appreciate it. But Kee, you wanna make a few comments?
Yeah, it's nothing like having, you know, one of your mentees on the panel with you. So I'm already like, everything's bonus at this point. But, you know, Ernest, he started his talk by giving the historical context. And I think this is so important. We don't want to just treat the symptoms and, you know, and fix the disparities by, you know, providing more services, equipment. We really have to get down to the root causes of why these health disparities occur in the first place. And I think I can't, and that's the social change part. And I think neurosurgeons have a responsibility to address these structural problems that contribute to healthcare disparities, not only in the US, but overall between high-income countries and low-income countries. And I'll get into a little bit about it in my talk, but you know, the idea of surgical training, the inputs, right? So we're surgeons, so we like to think about things like an operation. And so we have a scalpel and everything looks like an incision, right? But I think we have to think beyond the inputs, the additional surgeons, because we have to work on the health systems itself. Imagine we have all these surgeons coming out and then they don't have support from the ministries of health, either by, you know, having nursing staff, anesthesia, ORs, or even CAT scanner, right? So how do we go from tactical to strategic thinking, right? So this is where I think someone like you, Alfredo and Michael, you know, the maestros of surgical technique, you know, applying your expertise and your thought process into a more system level strategic thinking on how to change the world, as you say. Thank you.
I was thinking about it actually, Kee, and everybody, people, they have had a difficult time, you know, understanding our foundation. They think that we go and do surgery. We don't. I actually put, we partner with people, and you heard already Dr. Lawton talking about Dr. Rodrigo Ramos. You can see God, right? They are the surgeons. You guys are the surgeons around the world, people who are here. We go there to learn from you. And it's very important that people realize that. We go there to share a little bit of the expertise that we develop. We're privileged to be at places like Harvard, Hopkins, Mayo, you name it, right? And we can develop expertise in one special, but the reality is that the surgeons that we encounter around the world are amazing. We're also there to empower people to do more. We're not there to do, we're there to empower them. We build bridges with the community, we build bridges with politicians, with people empower. Some of them are our patients, actually the majority of them are patients who can afford to spend $500,000, $1 million to get their care in the United States at our institutions. And the other ones, when we go there, is like, we're going and say, can we partner with you to help those who may not have as much access? Because I think that is very, very symbolic. If we can build bridges, not only from here, from the United States to the rest of the world, but internally in these countries where sometimes there's not a lot of trust, you know, in their government, their systems, and they see us as the natural bridge to be able to do so. But, you know, you try to change the inside, the fabric of these places. And I think that it is our responsibility, as you said, Kee, and as you say, Ernest, our responsibility to do so, to be able to do so. And I think that's our foundation all about. And I got to tell you, when Mike and I go and operate with Rodrigo, with Victor, with God, we realize that you guys are extraordinarily gifted maestros in what you guys are doing, and we feel blessed that we're able to share a little bit of what we do and what we know. I'm gonna ask George. I see George right here who already made a comment. Dr. Jallo, who, by the way, he was also my mentor. I followed his career in intramedullary spinal cord tumors, and I got to learn, everything that I know about intramedullary spinal cord tumors, I learned from George. George, you want to make a couple of comments?
Having some audio problems, Alfredo. Let me get back.
Okay, no problem, no problem. Sounds good. Maybe then I pivot right now to Dr. Victor Garcia Navarro. Victor.
Hi everybody. Well, I think that all this experience has been amazing for us. And now I'm remembering when I was a resident in the National Institute of Neurology and Neurosurgery in Mexico City, that we were 6 residents. And two of these 6 residents, every generation, were from other countries. So we were trained 4 Mexican and 2 people from Ecuador, Chile, Argentina, Colombia. So I think that this is something that we learn when we have mentors like you, like Alfredo, like Dr. Rodrigo, and then this is the way that we can share with other people and with other countries. So when we share this experience that we had before, and this is like something normal, I think it's amazing. And find people from other countries that from some people we can receive and to another people we can give. So this is a magical experience. And now in this virtual reality that we had the last year, I was connected with Mayo Clinic, with Alfredo every Friday, and it was not only me, it was all the students. So we learned that this is not only presential, because all the people, I know, we want to have people around us all the time. We share the OR with Alfredo, with Ted, with many people, but I know that you cannot have like 100 people in the OR, but with this virtual reality, sometimes even we can share more the knowledge, and we can measure that. And I think that this is the way that we are learning and that we are sharing, not only with people from Central America, from North America, now from all over the world, and not only with neurosurgeons. Now that we have been sharing this teamwork model with neurologists and with nurses and with the students. And even we are sharing not just in the OR, in papers, in meetings. And I think that this is the most important experience that we have had more in the last year.
Amazing, Victor. This is great. I think that what we gather from your thoughts is that we have the ability to build bridges, not only in our profession, but other disciplines as well in other fields, which is equally important to be able to change this. And that goes back to the talk by Ernest to listen. I'm going to pivot right now to Rodrigo Ramos because he mentions empathy. We cannot teach our residents, we cannot teach our students, fellows, nurses, physicians, empathy. This is something that, somehow, somewhere, people who are bilingual, bicultural, is proven. There's been studies that they do actually have the ability to understand the world so much better. And I think everybody here has somewhere is connected to a different culture, to a different language, and it's so important in our brain. I published several papers that being bilingual allows you to do better resections, better control of epilepsy, better outcomes, and neuroscience has been known as well. Being bicultural also allows you to connect. But empathy is something that is really at the center of this. Rodrigo, please comment on this. There you go.
Good morning for everyone. This is my pleasure be here. Not only with the great professionals, I share the friendship, and this is a very important value in our connection. Certainly, the empathy is a primary function from the basic neuroscience. The empathy and the connection with the other brain is a part of the social brain connection. And this situation is very important to in critical situations, not only for the learning, is to change the behavior. This is the end point about the education. For this reason, is the best heritage to promote a change of the behavior in the future. And the education, the empowerment, the empathy is, in my opinion, a key, a work key in this work. And let us work together, share the same dreams, think globally, performance locally. And this is one of the most important points. Now, in the pandemic scenario, we need to take more information and more strengthened about the empathy, but also the resilience. The resilience we need about that, because this is important to work and to share this dream in the complex scenarios. It was a test, was a challenger, and now we are working in this project in difficult situation. But we are working together, and this is a best guarantee to work and to check the end point in the future. The empathy is my favorite word for work, for the teams together, for the communication with the people. And this is a key in this mission brain, the empathy, thinking in the others. And this is the best way to change the world. Thank you.
Wonderful. Thank you, Rodrigo. I think that we're keeping us in time. The next phase, April, what's the next in the schedule?
Yeah, that's actually a great segue from Dr. Rodrigo Ramos, because thinking about words that come to our mind, we will be putting links on our chat box for everyone to sort of participate. There will be prompts, phrases, and we want to know what the words you associate it with. And we hope to have sort of some insight as to what are everyone thinks about when we talk about these topics we're talking about. We will have further opportunities for more questions for our next speakers, but I think we're going to go ahead and talk about, we're going to present, why do we have the, I think we're going to go ahead with our second speaker, Dr. Kee Park, and will be introduced by one of our other team members. Mike, we can't hear you.
I'm sorry, April. I was just going to say thank you. I think that we have an introductory slide for Dr. Park. I think that we are going to have Andres Ramos, Mike, one of the two.
It's Mike. Yeah, Mike was talking. I think he was trying to introduce Dr. Park, but technically,
they spent some time, preparing these slides for you guys, beautiful slides that they put. So that Mike Pullen, do you want to go ahead and share your slides and introduce, Dr. Park?
Yeah, absolutely. Okay, can everybody see my screen, full screen? Awesome. So Dr. Kee Park is the Director of Policy and Advocacy in Programming Global Surgery and Social Change. He's a lecturer in the Department of Global Health and Social Medicine at Harvard Medical School. He practiced private neurosurgery for 12 years in the US before spending the next decade teaching neurosurgery in Nepal, Ethiopia, and Cambodia. He then returned to the US to obtain his MPH at Harvard Chan School of Public Health. He joined the program in global surgery and social change in 2016, where he leads the policy and advocacy aspects of global surgery, as well as the Global Neurosurgery Initiative. Awesome.
Take it away, Dr. Park. We're so honored to have you. And I just want to make sure that we are keeping track of all the different things in the agenda we're doing. So we're delighted to have you here. What a great honor.
Okay, can you all see me and the slide?
Yes, we see you and the slide very beautifully.
Yeah. So thanks, Alfredo and Michael and everybody at Mission Brain, April. So far, it's been just mind-blowing, the comments and the conversations that I'm hearing. This is exactly the kind of conversation that gets me really energized. So, and then thanks for inviting me. So my talk is about global neurosurgery, path to equity in neurosurgical care. And I guess the operative word this morning really is equity, and I love that. So I'll start with this slide. While the news is dominated today about Brittany is able to now regain her assets from her father, right? She's now, and by the way, I support that. I'm not taking away anything from Brittany. However, something else happened today, which is the comprehensive policy recommendations for management of spina bifida and hydrocephalus in lower and middle income countries went live this morning. And the website is chisper.org. And then, I'll get into a little bit more about this later. And this really has to do with what's happening in global surgery, global neurosurgery, a systems level approach, policy approach that's happening, which is an exciting development. So I'll start off with, a little bit about me. I started training neurosurgeons in Ethiopia in 2018. I went back and forth, and lo and behold, some of the people that I trained have now exceeded me in academic ranking. They're full professors at Addis Ababa University. And I'll make a little plug. We're actually starting a global neurosurgery grand round series hosted by the PGSSC. And our inaugural grand rounds is on November 23rd. And I'll share the link later on the chat. And we're featuring, the theme is global neurosurgical capacity building in LMICs, and specifically the Ethiopian experience. When I started working there in 2008, there were 3 neurosurgeons in a country of 90 million people, all in Addis Ababa. So can you imagine what would happen if you had an epidural and outside of there? Now they have 45 residents currently in training. So you can see if you want to hear more about it, please come to the grand rounds. But then after Ethiopia, I moved to Cambodia in 2013, and I worked at a government hospital and teaching neurosurgery with my colleague Yves Bichet. And it was around this time, I think many of you may know, the Lancet Commission on Global Surgery was released. It was published in 2015. It changed my life because I don't know about you, but I'm sure Alfredo and Michael and other people who work on the mission type of trips, you go and you can transfer certain skills and you can see them doing it again. And it's clearly that it's beneficial. But at some point you get really frustrated because you're saying, this is helpful, but you're only scratching the surface, and we need a revolution, not an evolution. And that's when the global surgery, the report from Lancet Commission, when it was published, it really talked about a health systems approach to ensuring surgical care for everybody around the world. And so I came back to the United States. I signed up for the global surgery program as a fellow, and then stayed on as faculty. And so one of the things that we started was a fellowship for global neurosurgery, and you'll see Ernest is here. And we've had 6 previous fellows, Michael Dewan, Kerry Vaughn, Jacob Lepard, Ernest, Jackie Corley, and Adam Amar. And they're all from the US, you might know that. And we just made an intentional decision last year to start looking at neurosurgery trainees from outside of the US. And our current 2 fellows are from Egypt and one's from Malaysia. So the PGSSC, our vision is really what the Lancet Commission on Global Surgery has envisioned, which is universal access to safe, affordable, and timely surgical care, obstetrics and anesthesia care. And the program in global surgery does this not actually, we don't actually go to countries and train anymore. I think there are excellent organizations that do that. For instance, Mission Brain and other groups, Fiends is another one. But we actually focus on strengthening system level changes, strengthening surgical systems as part of UHC. And we do this through research, policy development, advocacy, capacity building, and training future leaders in global surgery. So Ernest was a perfect example of someone that we've had the honor of hosting, and now he's really a change maker, not only in Haiti, but in the field of global neurosurgery and global health. Our values are rooted in social justice and equity. As I mentioned earlier, we really feel that health disparity is really a symptom, and there's a much larger structural problem that we want to try to address. So that's PGSSC in a nutshell. So what are some of the activities that we're doing at the program in global surgery? So remember, our strategy is to strengthen global surgical systems. And so we work with ministries of health, the WHO. So the program in global surgery is actually a WHO collaborating center, official collaborating center on surgical system strengthening. We work with development finance institutions like World Bank, Asia Development Bank, and so on. And we work with ministries of health and then to encourage them to develop national surgical plans. And there was some chat earlier about Nigeria's national plan. We work with a number of countries. And a national surgical plan is where we go from tactical to strategic, right? How do we come up with a plan, a multi-year, costing really hundreds of millions of dollars, but that is a plan for the government, that is written by the government and implemented by the government, that includes elements of, how do we scale up neurosurgeons in our entire country? How many facilities do we need to treat neurotrauma in our country? So you can see the implications for this. If you get frustrated by saying, hey, I want to do more for these people in developing countries, this is the way to go, right? We get at the highest level of buy-in. And we've assisted with a number of countries in developing their national plans: Zambia, Rwanda, Tanzania. Now we're working with Fiji, Palau, Tonga, Nepal, Pakistan. So there's right now, and we do this through workshops in person, but now we've gone to virtual platform due to the pandemic. We have over 44 countries now engaging in various levels of national strategic plan development for surgical system strengthening. This is something that's been happening. This is the global surgery movement that I think not too many people are aware of. And I'll tell you what happened recently. I was at Berlin at the World Health Summit because we hosted an event about universal health coverage and surgical care. And we actually had the executive director of UNFPA, who is the agency responsible for sexual and reproductive health, Dr. Natalia Kanam. She was part of our panel. She talked about how emergency obstetrics is an essential part of universal health coverage, and that really has to do with surgical system strengthening. We had the health minister from Ethiopia, the people from WHO, and then John Miro is our director. He couldn't go, so he joined virtually. I actually went in Berlin in person. But what happened in Berlin was that the vice president's office from Ecuador contacted John Mira saying, hey, I want to meet you in Berlin because we want you to help us strengthen our surgical system in the entire country. Well, John couldn't go, so I ended up going. So I'm meeting with the vice president of Ecuador. His name is Alfredo Borrero. He's a neurosurgeon. He's a neurosurgeon of all people, as a vice president of Ecuador. And he oversees the health ministry, the military hospitals, and the private sector. He said to the Harvard group saying, hey, can you help us strengthen our surgical systems? I said, of course we can. So we've had follow-up conversations. But what I'm saying is global surgery is now at a tipping point. It's no longer a neglected stepchild of global health. Vice presidents are talking about doing it in their countries. So let's go and say, where does neurosurgery fit in all this? And I'm happy to report within neurosurgery, our profession is kicking butt compared to other specialties in surgery. I'll tell you what happened. So the Lancet Commission report in 2015 was released. That's what changed my life. And then at the same time, WHO hired Dr. Walter Johnson to implement the resolution that was that called for strengthening of surgical services as a part of universal health coverage. Well, Walter Johnson, who's overseeing this resolution implementation, he's a neurosurgeon, right? So we have the top guy at the WHO overseeing surgery, neurosurgeon. And then we have Bob Dempsey, who I think you all know, he's the chair at Wisconsin with Fiends. the three of us said, looked at each other and said, we need to do something about neurosurgery. And we did. We had a strategy meeting in Geneva in 2015. We said, let's make this into the meeting the unmet neurosurgical needs globally, a neurosurgeon's responsibility, not somebody else, but we're going to fix that too. Not so much how to do surgery better, but how to make sure that we can better deliver surgical care to all who need it. So we actually started off with a declaration in Bogota in 2016. Franco Servidai from WFNS was there, Andres Rubiano. So there was a declaration. And I think you all know over the last 3 or 4 years how, as I think Michael Lawton earlier said, it's a hot topic. Global neurosurgery is no longer this, what is that? It's a hot topic. It's become a plenary session at the World Congress. We now have a workforce map on the WFNS website. We're having global neurosurgery themed conferences. Rutgers just had the second one this year. Last year they had one virtually, but second one was this year. Cornell Group is having another one, and I think just another week, a week from Friday, about global neurosurgery education. So it is really a hot topic right now. So we published this paper in 2016. The research output with using the tag term global neurosurgery is exploding. I think we went to the WFNS meeting in 2019. Jim Kim gave the Cushing oration. He was the former president of the World Bank. He used our slide showing how much the research output is going up. It is exploding, and it is a thing now. So one of the things that we did at the program in global surgery is that we wanted to do a baseline. Where are we? What situational analysis? Following the exact playbook that the Lancet Commission did. And we estimated the number of neurosurgical operations that were currently not being done. And it came up with a number of 5 million operations. And we also looked at it based on regions and income levels. And you can see on the map, it's not you can see where the gaps are. It's in Sub-Saharan Africa, South Asia, and Southeast Asia. And then we also did the workforce assessment, and we estimated that 23,000 additional neurosurgeons are needed today to meet that gap. So how are we going to get there, right? So everybody says, okay, we're going to train more neurosurgeons. I think that makes sense. And as I put in the chat earlier, it's an absolutely essential part of global neurosurgery to meet that gap, but it is not sufficient. We have to think much more in a systematic way, and I'll get to that in a minute. So one of the key projects that we worked on was the comprehensive policy recommendations for head and spine injury care in lower middle income countries. Why was this important? Because as I mentioned earlier, countries are not developing national surgical plans, and they use the WHO's building block methods, the framework, infrastructure, workforce, financing, information management, service delivery, and governance. So we took those 6 building blocks and then and looked at the head and spine injury spectrum of care. Okay, not just surgical care, but everything from surveillance, pre-hospital care, prevention, and surgical care and rehabilitation. And then we scoured the literature based on these, the matrix, like what are the workforce requirements for rehabilitation? What are the financing requirements for prevention, for instance? And what we found is, number one, the research output on head and spine injury is almost all focused on training. It's because neurosurgeons are writing it. And we only know, we're comfortable with in that space by training more, how to train. But we just don't have the expertise in many ways to talk about financing of surgical care, neurosurgical care. What are the affordable, how do we make it affordable? Is it accessible? About the quality of neurosurgical care, is it just inputs? How do we make sure it's safely done? So there was what we discovered was there's a paucity of research out there. And I'm going to quote this one paper. This is, one of the recommendation was, is there a golden hour for TBI in LMICs, right? We talk about that in the US. And for mild TBI, this is from data that we collected in Cambodia. There's a gradual deterioration in Glasgow outcome scale, as that correlates with the delay in arriving at the hospital, but not very significant. But if you look at the moderate TBI, after about 4 to 5 hours, there's a precipitous decline in the outcome as it relates to the delay that between the time of injury and getting to the facility. And this was a paper that Ernest was the first author on. And we said, and the policy recommendations, you might be able to put neurosurgery trauma facilities as far as, let's say, 8 hours from every other place, right? So there's a 4-hour window for people these patients to get to the hospital. That has big implications for ministries of health, because they're asking, do we need to have a CAT scan in every district level hospital? Probably not, but they need that kind of expert recommendation. They weren't getting that before. The other question was, how many neurosurgeons do we need to manage our neurotrauma burden in a given country? Our estimate was 1 in 200,000 people. So we just, at the beginning, I showed you the comprehensive policy recommendations for the spina bifida and hydrocephalus management. And we did this because we wanted to link our efforts to the pediatric surgery community. And hydrocephalus and spina bifida was the right disease to choose. And we had a number of organizations that supported on this. We're still taking supporters. If you wanted to take a look at it and endorse it, let us know, and I'd be happy to send you a copy of it. And this just went live this morning. And the idea is that we will take these recommendations and provide it to ministries of health so that they can embed this right over top of their national surgical plans, which uses the identical framework, the 6 building blocks of health systems. And this is how we wrote these recommendations. So one of the things I mentioned was that there's a paucity of a research output. And if you dig a little deeper, right, and as we talk about structural problems, the medical publishing industry is a cartel. Okay, it is completely set up in a way that makes it very difficult for researchers in low and middle income countries to conduct research and also publish and access those research. So we actually started a journal of global neurosurgery, 0 article publishing fees, and it's all open access. And its entire ethos is about equity in neurosurgical research. And then the new issues coming out, second issue, it's on pediatric neurosurgery, and will actually feature the comprehensive policy recommendations that I just showed you on the website. And it's dedicated to our colleague and friend, William Harkness, who was a champion for pediatric neurosurgery. And Ronnie is on this call here, and he's a guest editor on this issue. He's a contributor on the policy recommendations project. Thanks, Ronnie, for all your contributions. So I'm going to close up with this last part, which has to do with the World Federation's approach to global neurosurgery. There's a lot of discussion about global neurosurgery. It's a hot topic, but sometimes people really don't have a clear idea of what is global neurosurgery. And we have as many definitions as there are people. So we came up with a definition there, and I would love it when if you all use this definition so that we're all on the same page. And this is the World Federation of Neurosurgical Societies definition. It is the clinical and the public health practice of neurosurgery. So it's really a discipline of neurosurgery, right? It's a practice, but we're emphasizing the addition of the public health aspect beyond the technical mastery that we are so good at, but we want to add the public health strategic type of thinking. It's with the purpose, and there's a purpose to this. It has to do with equity, ensuring timely, safe, and affordable neurosurgical care to all who need it, right? It has to do with making sure that it's especially the ones that aren't getting it today, that they're the focus of our attention, right? And I want to emphasize that once again, we tend to focus on the workforce and the training part. We need to look at the big picture, all the other pieces of the pie, service delivery, policy and advocacy, financing, other things as well. So one of the things that we launched was a global neurosurgery action plan with 5 major objectives. One is to amplify access to neurosurgical care. Remember, we don't do the actual service work. We would put things to facilitate this. So we would track, for instance, the neurosurgical workforce globally, right? How many neurosurgeons are there? As long as we're tracking it, we can facilitate the increase in the rate and see if we're getting there on time or not. Aligning all global neurosurgery activity, advancing relevant research. I think this is research equity, as I mentioned before, making sure that neurosurgical capacity building does not happen in a vacuum, that we are aligning ourselves and assimilating with national surgical plans. And I think we're well on our way to do that. And at the end, we have to all advocate for neurosurgical care for all. And we should be doing that along with the surgical community and global health community, right? We co-advocate. We don't just advocate for ourselves. Just to give an example, just looking at one of the objectives, we have discrete targets that we set for ourselves. And I will tell you that we're on our way to hit almost every one of these targets. And we'll be announcing this in Bogota in March of 2022. For instance, we have already mapped the research output by region and themes. And this is to see where the major gaps are, which themes are not being researched on. And then saying, hey, look, governance aspects, managerial aspects of neurosurgical care in developing countries need to be, we need to pay attention to that. We have established a global neurosurgery research grant, thanks to Philip Aldana and Carmina Aldana from Neurosurgery Outreach Foundation. They gave generously, and there's a research grant specifically for authors from LMIC. And so that's already up and running. We'd love to do another one, and let us know if you're interested in funding such a thing. One of the things we wanted to do was to have major neurosurgical journals establish sections, right, on global neurosurgery. As you know, there's sections for tumor, vascular, and spine. I'm a spine guy, all those things. But then everything else gets into sort of miscellaneous or socioeconomic. No, we're going to have our own section, global neurosurgery. Well, we went one step further. Not only do we have major, our neurosurgical journals now have sections on global neurosurgery, as I mentioned, we have our own journal, right? So I think we've exceeded that. But you can see what we're trying to do here. We're trying to actually transform the way we think about neurosurgery, make and start some changes that will end up yielding these outcomes that we're looking for. We're not trying to fix the problem today, but we're trying to change the institution of neurosurgical profession really to embrace the fact that there are these massive gaps in neurosurgical care, and it's our responsibility to meet that. So I just want to say thanks for listening, and then if you want to hear more about our global action plan and where we are with that, we'll have a full presentation in Bogota. I think the Vice President Borrero from Ecuador is going to make an appearance at this event. So Alfredo will have to go down there. And I'm just happy to report that I've been appointed as the chair for the next cycle for the global neurosurgery for WFNS. And watch out, we have plans. So thank you.
Beautiful talk, Dr. Park. Key, there's so much activity in the chat, so many questions. My WhatsApp is going crazy. I actually was communicating with Alfredo Borrero, who I know since I was at Hopkins in 2007, came in and spent time with us. And, it's such a small world. And Alfredo's been very committed from Ecuador. There's a lot of connections. I see so many people. You just remind me, I just took some notes, same as I did with the other one, all right? I was looking at this right here, and I just took some notes just to stay, into the some of the themes that you touch upon and some of the quotes. You said early on, we need a revolution. And I think everybody got so excited, to see that, because that is absolutely true. That revolution, there's no question that it is needed. And then you went on to say that there are 5 million, and that's probably an underestimate, 5 million surgeries that are needed, in the world today. All right. And that's probably an underestimate. I mean, given the population, but just think about this. And just in neurosurgery alone, we need additional, probably also an underestimate, 23,000 more neurosurgeons that we need to train, all right? And it is our responsibility as leaders to do it. You remind me of 2 quotes. One by a very, someone who I consider to be a role model for me in the United States, who was also a migrant farm worker, Cesar Chavez. Cesar Chavez said once that to make a great dream come true, he said, to make a great dream come true, the first requirement is a tremendous ability to dream. All right. And the second requirement is to put those dreams to work, basically to execute, to persevere, to not give up. And I think that that's exactly what you were doing. Dr. Barthélemy is doing, Ernest as well, everybody in this. The second quote that you reminded me is that we fail. I mean, we fail miserable. I have written about this. I have failed more times than I have succeeded. And it reminds me of that quote from Winston Churchill, that success is going from failure to failure without the loss of enthusiasm. And I just want people who are listening to you, to your talk, our youth, to realize that we fail in everything that we do, but it's through that failure that we build extraordinary things. Success is necessary to build the confidence. Failure is necessary to build character, but it's both together, success and failure, that would allow you to build wisdom. And that's something that I think that is becoming more clear. So I'm going to open up. I think, April, do we have some minutes for some other comments and questions right here? How are we doing in time?
We do. We're doing fine. I'd like to open up the questions. We have some questions that were pre-posted, and then we have some current ones that are just coming up on chat right now. The first question, actually, I think, Mike, you have on your list, there's one from Dr. Legaspi. So if Gap is available, if you could ask the question himself, I think that would be fantastic.
Go ahead, Gap.
Thank you, April. My question is really, how do we measure the success of this intervention as a way of, planning the next steps after the initial one? So, in a very complex specialty like neurosurgery, and especially like us in the Philippines, it's a big archipelagic country. So, just want to probably see how the steps will go, and I think part of that is assessing initial successes and then going further from there.
Yeah, Gap, great question, but I want to just follow up on the failure part on Alfredo before I start answering your question. So one of my favorite quote is, "We only fail when we fail to try." So I wanted to make sure I get that in there. So Gap, you're absolutely right about it, right? How do we measure success? So one of the things that Lancet Commission did was put in 6 indicators, suggest 6 surgical indicators. They're sort of broad indicators, things like number of surgeons, obstetricians, and anesthesiologists per 100,000 people, the number of operations per 100,000 people, the percentage of population that could be impoverished if they access surgical care, and for safety, they chose perioperative mortality. So these are indicators, and actually the World Bank has included, I think, 4 of those into their World Development Indicators. So we successfully lobbied to get those indicators as the World Bank to start collecting. So that's very helpful. But at the end of the day, I think for me, it's the outcomes in human lives and disabilities, right? So things like what percentage of the population currently are dying of head injuries and from motor vehicle accidents in Philippines, right? I think that's something, if we can measure that and we start implementing large scale neurotrauma interventions across Philippines, and you see a reduction in those numbers, right? You see less people dying, less people being disabled. I think until we start seeing those numbers, we should not let the pressure off.
Great, thank you so much. Do you have anything else you want to add to that, Gap?
Just that for now, April.
Great.
I just want to say, between Gap and Alfredo and Michael Lawton, we have like the 3 most famous people in neurosurgery right here.
That's all of you guys. We're so blessed to have you all. We have a few other questions already, April, that you guys had actually, some people had already pre-asked questions. This is a good
we've
moment.
got a lot of questions, but before we go over to 3 other questions that actually have just been posted, I want to also just ask Dr. Baticulon to comment, because he's been involved in this project.
Thank you, April. Thank you again, Kee, for that wonderful talk. Kee and I have known each other since my time in Uganda, so that was 2016. So that was how I got involved in global neurosurgery projects. So when I was in Uganda, I was there with Michael Duan, who was then a fellow of the Harvard Global Surgery Program. And since then, I've been, most of my research work has been in global neurosurgery. And I'm happy to let you know, Kee, that actually this year I'm leading a project on the national neurosurgical workforce in the Philippines. So we're trying to map out the national neurosurgical workforce in the Philippines and how we can be able to provide essential neurosurgical care to the Filipinos. And actually what we're doing is we're using the Lancet Global Surgery Framework as our parameter for this. So it's I'm really excited about it, and I owe it a lot to having worked with you and your team, and knowing how to navigate all these things. Now, I think what I really liked about your talk was that you emphasized that most of the time, most of global neurosurgery work, most of the times people just focus on the workforce. So that's why most papers in global neurosurgery usually just tend to look at the number of neurosurgeons, the number of operations and all that. When in fact, when you have to take care of someone with spina bifida or hydrocephalus, it's not just the neurosurgeon is there. And you see what another global surgery paper that I really like is the one on the 3 delays. So it's the one that examined the causes for maternal mortality in Haiti, where they were able to determine that they were able to identify 3 causes of delay. So delay in seeking care, delay in reaching care, and delay in receiving care. And that's a very important framework. And that's where you realize that it's not just having a surgeon or a neurosurgeon in a hospital or 2 hours. Actually, what they use is 2 hours. How many patients are within 2 hours of healthcare facility where they will be able to get the neurosurgery that they need? So, but it's not just having a surgeon there. You also need to consider what are the factors that are hindering these patients from seeking consult. Is it because of their beliefs? Is it because of their distrust in the medical system? Is it because they have to travel 7 hours by boat or by bus, or they have to find some transportation? Or when they do get in the hospital, what are the reasons why there's a delay? And you realize, as Kee said, it's a lot more complicated than having neurosurgeons or people doing the operations. And I also wanted to mention one of the things that Ernest mentioned earlier that I really like is that the global surgery movement is about providing care to the people who most need it. So that's the core of equitable care. So it's not just giving equal care to everyone; it's giving it's giving help to those who need it most. And while I'm here, I also I agree that there's really the momentum for global surgery is here with us at the moment. But I think at this point, I also wanted to highlight one of the things, especially this year, that has also been gaining ground, is the move to decolonize global health. And I think that that is also important in global surgery. So when we say decolonize global health, so if you look, for example, at the top global neurosurgery papers, so these are papers that aim to improve access to global neurosurgical care. When you look at who are the first authors and last authors of these papers, they are from high-income countries. And you see that the majority of people who LMIC authors are usually left in the middle or have very little contribution or are not acknowledged properly. And personally, I have seen, for example, papers about providing neurosurgical care in the Philippines, where some high-income country surgeons write about their experiences providing care to our patients and not even a single co-author from the Philippines. And I've also read the paper on, for example, trying to review providing trauma care in low and middle income countries, where all of the authors are from high income countries, and there's just one single middle author from a low income country. And so you're beginning to wonder, when they do write these recommendations, is that right? And I think that it really is. I mean, we really appreciate. I mean, for us from low and middle income countries, we really appreciate the help because that we get with these partnerships. But I think it is also a good time for our partners in high-income countries to try to examine what are their goals. What are your goals exactly in trying to do these programs? Because to be honest, sometimes what's being said right now is it's just like being invited to the table, but then actually being asked to speak or something like that. Sometimes you have to look at those things. And when you do have these global neurosurgery partnerships, even the small things matter. So for example, it's as simple as rotating the times of meetings. So for example, when you do meet with global neurosurgery partners, do you actually rotate the meeting time so that it's not always the LMIC collaborators who are having to wake up early in the morning or having to stay up late at night? Or it's also as simple as making sure, for example, that when the order of authors, that the authors are properly acknowledged for their work. And it also has to do, for example, with publication. I mean, when the problem is, for example, LMIC authors, when we try to publish our work, we are sometimes compelled to write to please HIC editors and reviewers. And there's a lot of barriers for LMIC authors, when in fact, we are the ones who will need that data, and our colleagues in LMICs are the ones who will use that data most. So again, these are important questions that we need to ask ourselves. While the global neurosurgery movement has very important goals, and as we try to do our best for everyone, I think for it to be truly equitable, for it to be truly empowering for everyone, we just need to make sure that these things are addressed. Thank you again.
Beautiful, Ronnie. And April, how we do with time? Are we good? Do we have time for a few more comments, or you want to show something right now?
We do. I would really like to acknowledge what Dr. Baticulon also said. And in that vein, we miss a lot of marks in so many things here. We just had a very interesting conversation earlier before the start of the webinar. But before I take any questions, I would also like to acknowledge Alfredo, our one and only female panelist in the webinar today. And we are so glad she's also the only neurologist here. So we're very glad to have Dr. Diaz Alba join us. And we'd like to hear from her and what her thoughts are on this matter.
Beautiful.
Hi, thank you all. And thank you for the invitation. Well, I'm not a surgeon, so it's really interesting to listen to all of you and to know all the adversities that you have when giving care. So as a colleague, I would ask you how to do this mentoring, the mentoring relationships that sometimes for the non-surgical colleagues, it's more difficult. You tend to spend hours during the surgeries with all the doctors in training. So it would be very, very interesting to know how you get to make interested doctors in promoting global care.
Would anyone want to take that question? Dr. Park, perhaps?
Sure. How's this? Yeah, great question about mentoring. So I don't think the mentoring is limited to surgical skills. I think it's beyond that, actually. So our program in global surgery at Harvard is non-clinical. So what Ernest did was research, policy and advocacy work, and then so that it's not limited. It really has to do with identifying people who who are in a position to guide the younger generation. And then I would say beyond mentoring, there's the whole concept of sponsoring, which is where not only do you give guidance, but you actually give them opportunities and place them in positions where they can flourish. So there's one extra step that I think we can go for our mentees and sponsees.
And I may just add to Dr. Park, I think that there's a fine line between being a mentor and a tormentor. And some of us cross that line very nicely and easily. I am guilty as charged of that. I mean, everybody who has worked with me, they know that I push myself very hard and I push those around me very, very hard. But somehow I continue to be surrounded by the most brilliant people, and that's been the key to my success. But I also think that you have to encourage our youth to have this thinking that if you have an idea, you have to chase it, you have to dream it, you can't let it go. It's so easy to let things go, to give up. It is much, much more challenging to imagine and to see light when the rest of the world only see darkness. And right now, we are at a critical time in our lives, social media, communication, everything. You turn the news and everything in the world is ending. Or suddenly they're giving news about Britney Spears, when there is something about spina bifida and hydrocephalus that can change millions of people's lives, and is not even making the covers of our own, circle and the things that we're discussing. I think that that's where we need to make sure that we hold ourselves accountable and we hold those mentees around us accountable as well, so that they can continue to change the world.
Great. Thank you, Alfredo. Dr. Park, thank you so much. there are 3 questions that I would really like to go back to from our audience, but in the interest of time, and I really appreciate all these questions from them, and they are part of, they should have a seat at our table, obviously, as well. So it's really important to give them the opportunity to ask these questions themselves. But before that, I will like to introduce Paola Meade, who has who's going to introduce our scholarships and also the chapters, our student chapters all over the world. Paola.
Thank you, April. Let me just share my screen. Can you see it correctly or the other way around? Perfect. So we just wanted to follow up the line in Dr. Diaz and Dr. Park's mentorship and sponsorship. And we want to take a quick break on the talks and to give out a couple of announcements. First is our Lisa Hannegan Humanitarian International Neuroscience Scholarship. Carlene and Carla were saying that Lisa is smiling at us, and it's completely true. And we did that in her honor, and we want to support and sponsor 6 different individuals to travel for an observership or training or research activities in our different partnerships institutions, and we will be providing $6,000 per individual. Our applications are open now until January 31st of 2022. So I want to encourage all the attendees to apply, to propose your project. We have been getting a lot of requests, and we will be giving 6 scholarships to the most impactful projects. So Mike, do you want to talk about the student chapters?
Yeah, absolutely. So something we just recently launched was our Mission Brain student chapter program. And this is to connect medical students, high school students, college students from all around the globe in an effort to forward global neurosurgery and accessibility. So I'm going to ask all of our participants, if you are from a chapter, to put it in the chat so all of our panelists can see where we're all from. We have over 30 chapters right now from schools all around the globe. So please put your school in the chat. And you can see here from 9 countries, with our most recent chapter from the Dominican Republic. And right now we have all these chapters connected in Slack, and the idea for these chapters is to both increase exposure for medical students to neurosurgical problems. We'd like to connect them with each other because, as you know, the way you become a more well-versed individual is to talk and experience people who are not like yourself, and to learn about problems and challenges that you might not have known. And that's the main idea behind these chapters, is to connect people and to learn. We're going to begin offering observership opportunities. Again, we have the Lisa Hannegan Scholarship, which is open to everybody. And we also like to just see what these chapters do. So for example, our Mission Brain India chapter is opening up a smart clinic in rural India, where they provide free care to those in the area. We have people doing fundraisers. We have people doing special study halls for students. It's just really amazing, the creativity that our chapter members have had. And we're growing too. We opened this program up maybe about a month and a half, 2 months ago, and we're already at 30 current chapters. So we're going to aim to hit 100 maybe in the next few months, and keep doing a good push. We're also going to be forming a social network through Mission Brain. So it's going to be integrated in the Mission Brain website. It's going to almost serve as a LinkedIn. So you could direct message people. You could put postings for observerships and internships, research positions, and we could just have everybody have a nice collaborative environment. Again, I just want to thank all of our speakers and panelists for joining. The events like this aren't possible without the participation of people like you. And so we are so grateful that you guys are here. And we hope that maybe one day you could host some of our chapter students who would love to talk to you more. And maybe you would like to build some bridges and some connections. But again, thanks to everybody. If you have any questions, feel free to send me an email. I'll put my email in the chat. But again, thank you.
And we also have a couple of countries that we don't have a student chapter from, like Nigeria and Ethiopia. So we want to invite you to apply for a chapter, and we would love to have you being part of Mission Brain.
Yeah, also the chapter application, all the information you need could be found on missionbrain.org. So www.missionbrain.org. There's a big menu item that says chapters. So click on that. You could see all the information, see the application. You could see our current chapters, what they're doing. So we really appreciate everybody.
Great, thank you so much. That's great, Mike and Paula. They've really done a tremendous job in putting all of this together. We just also completed our fundraising run about a month or so ago, and that also drummed up a lot of participation. And I think this is really an important platform for all of us to connect, because these are going to be the people who are going to lead us into the future. So we are so happy to be able to provide that opportunity for people to get connected. On that note, I'm going to go back to some of the questions here before we proceed to our last speaker. If you guys don't mind, indulge us a few minutes just to make sure that everyone is heard. If Shreya Sriram is there, if she could be unmuted and she can ask the question herself, that'd be great.
Shreya, can you hear us? She put the first question right there. She's from India. She's been so active in the work that they're doing in India. I don't know if JJ or Ryan, can you guys help us unmute her?
Was it Shreya?
Yes.
Yeah.
Shreya, you can speak if you unmute.
If Shreya is not available, we can go ahead with Neha. I hope I'm pronouncing your name right, Rao.
Now you have the ability to speak if you unmute. There you go.
Hello, everybody. Greetings from India, Bangalore. I'm Neha Rao. I'm a medical student. I'm delighted to have an opportunity to be part of this panel and speak to such great leaders in neurosurgery today. My question is to Dr. Park regarding his talk which he just had. When do you foresee that every person in the world would have access to equal healthcare in the world?
Let me just check with my wife. I don't think anyone really knows that, Neha, but I think we should have an aspirational goal. That's the idea behind the Sustainable Development Goals. So one of our target, if you look at it, is this is the WHO, 80% of the global population to have access to emergency and essential surgical care, where actually neurotrauma is part of that, but within 2 hours. That's sort of the target that everybody set for for the global surgery community, and the target date is 2030. It was aspirational prior to the pandemic, and now with the pandemic, it's probably for sure we're not going to hit that, but we should be striving for it, right? We need to have a objective in mind.
Thank you so much, Dr. Park. It's truly an honor to have visionaries like you leading the forefront of neurosurgery and medicine across the world. Thank you, Dr. Q.
Thanks so much, Neha. Is Antonio Composto still around? Would like to ask a question.
And tell us where are you, Antonio? JJ, yeah, if you can unmute yourself, Antonio, tell us where you are and ask your question. That'll be terrific. And JJ, I see Shreya is also ready to connect. She was having connection problems. You can, put her on the ability to ask a question. That'll be terrific. Antonio, go ahead.
I think we'll go ahead with Shreya because I think she's unmuted. Go ahead.
Yes.
Hi, it's a great honor to be here. So I just wanted to ask Dr. Park, I'm so glad I really connected with the part where you said that traveling to other countries and providing neurosurgical care, or something that we're doing with India chapter right now is create a smart clinic so that we can give more services under Mission Brain India chapter. But I really think that's not solving the problem. Like you said, it gets really frustrating because it's not solving the root cause. So how do you think we can ensure equity, as a whole for Mission Brain India chapter? So yeah.
Great question, Sharia. So I think the solution here really is who is ultimately responsible for the health of the population of a country? It's the government. But the government has to respond to the population, right? The needs of the population. So they have to speak out. Students, so by the way, the solution for the unmet neurosurgical needs, or surgical needs for that matter, is not technical. It's not going to be solved through operating our way out of it. It is really political and socioeconomical, right? So students, your voices, as someone who sees an injustice, when you see a patient who is unable to access simple neurosurgical or surgical care, speak out and say, why are we not having basic emergency essential surgical care, neurosurgical care, and why are people getting unnecessarily disabled or unfortunately dying? Your voice, even one person's voice, matters, and it's not. And then you can pair up with others and within India to amplify that. But I would encourage you to be bold and write somebody at the top level of the government, because you know what, your voice matters. Yeah.
And I can tell you that Dr. Park, Rhea, and Nika are very, very amazing. They're going to the highest levels, getting everybody organized and motivated and sending letters to the highest levels of government. They're doing amazing things. So it's amazing. They're doing organically, and a lot of it has to do with their own energy and their own vision, their own dreams, and not giving up.
Well, when you write those letters, and make sure you join Twitter and you tweet it and you tag me and Alfredo, and we'll amplify the crap out of it. Yeah.
I think we hosted a video for Mission Brain India chapter where we said what we're doing right now is just a band-aid, and without our country's government being involved, it's definitely not possible. So that was the first step we took. And the next step is obviously Dr. Q is coming to the inauguration, and then we're so excited. The only way I think to reach out to the masses is to reach the government. And thank you so much for the advice.
Beautiful. Well, let's see. April, can we see if we can unmute Antonio? He's having difficulty unmuting himself.
I think he's having difficulty. We can go back, in the interest of time, we can go back to Antonio while we figure that out. We will take one last question for this segment, at least, from Mohammed, if Mohammed can unmute himself. If we can go, Mohammed, are you able to? There you go. Perfect.
I think he is here.
Yeah. Hello, everyone. My name is Mohammad Amar Haider, and I'm a medical student from Lahore, Pakistan. And hello, Dr. Park. So, Dr. Park and Dr. Ernest, it's like attending Coachella with Beyonce and Jay-Z headlining. And it's so good to be here because not only the way they inspire all of us to do it, like the words they use, the quotes they use, they touch you, they go through you. So thank you so much, Dr. Park and Dr. Ernest, for that. And my question, before going to the question, Dr. Ernest shed a light on Haiti and how Haiti, was the first independent Black nation. And he mentioned how Haiti faced a lot of repercussions from the global north, especially France, in terms of reparations and all of that. So how do we provide neurosurgical equity to areas of the world, where we have these kind of governments or sanctions in place that don't allow for equity to be provided in these areas, or not a working government in itself? Because many, because there's so much instability in some of the countries, because of some of other countries, there are no true governments there. So how do we reach the people? how do we bypass that, the sanctions and the governments and all of that? That is my question. Thank you so much.
Thank you, Mohammed. I'm trying to figure out whether I'm Jay-Z or Beyonce. but thank you for an incredible question. And my reply, I actually had my own version of a question like this to one of my colleagues and friends in Haiti, Ernest Barthe, who happens to be one of the Lancet commissioners from Haiti. And I asked her in a small think tank that we organized around global surgery and national surgical planning in Haiti, what should we do now, or what can we do, or does anyone dare to envision a solution, a way to continue to make progress, despite the fact that the Haiti was in such a catastrophic condition sociopolitically? And then she corrected me and said, not despite the fact. She said, especially given the fact that the country is in such catastrophic socio-political shape, what can we do? And I really appreciated the perspective. The answer is not a simple one, but what I will say is, I don't think bypassing the government any way that might show up for anyone hearing that term will work, certainly not in any sustainable long-term manner, given what we just established about the role of the government in a population's health. I think the way to start is, first of all, remember that there are human beings there, wherever it is in the world that you're talking about. There are human beings just like you and me living in that awful, awful situation. And so that conversation really starts with those other human beings there and establishing contact with them, having conversations with them, looking at, well, what are they dealing with? What are their critical needs? There is a balance between looking at what can we do in terms of the practical solidarity. So is it, are you having a critical water shortage right now? And so your surgeons can't, certainly can't scrub for a case, let alone, have water for their basic needs. Are there any partnerships that you can help them to establish to address this critical, state of humanitarian emergency? And I think having those conversations will have some options show up for what to do in this short term. And then resting assured that, these emergencies, just by their nature, will pass. They will transition into another phase. And so the conversations that prepare for what will we do when life moves on to something that's quote unquote back to normal, when we know that the back to normal was already an abnormal state of affairs from the perspective of global health equity. And really that takes a commitment to the larger vision that you are committed to, working with people towards in a society. And so if it's, as Dr. Park said, training is something we think about easily, and there is a real need there. So are there training needs you can fulfill remotely? Are there people you can partner with to have that training have both a distance component and an on-site component? Are there windows of opportunity to travel safely? Haiti, for instance, most of what we learn in the United States about Haiti is focused on the capital city of Port-au-Prince. It turns out that Haiti is much, much bigger than Port-au-Prince. And there are actually many ways to get into Haiti that don't require going through the airport at Port-au-Prince. But there's obviously a very important risk-reward consideration. There are many ways, but it starts with the will and the commitment. I think once you give up the fight, then there is no solution. But when you remain committed to the vision and remember that there are human beings there too, we tend to find a way wherever we are on the planet. So I hope that's helpful, Mohammed, and thank you for your question.
Beautiful. Thank you, Ernest, and thank you, Mohammed. Were we able to activate Antonio?
I don't think so, but we'll keep working on it. In the meantime, we are gonna keep moving forward just so we could accommodate everyone and get everything running according, at least according to time. So thank you all very much. Those are great questions, and really there's so many points of discussion here. And from my point of view, we're just getting started here. So we're gonna go ahead and present just a quick update from our treasurer, Will Aarsheim. JJ, are we good? Seems like we're having some audio problems here right now.
We probably just need to share the audio, JJ or Ryan. We're gonna give it another try.
Sorry about that.
Try one more time. Sorry about that.
Hi, I'm Will Aarsheim, the treasurer of Mission Brain, and thanks for coming. It's great to see a record turnout for the symposium. Now, you may be wondering why an all-volunteer organization like ours needs to raise money. It's because we're growing. First off, we've established 4 international scholarships for doctors and nurses in honor of our friend and founding board member, Lisa Hannegan. We provide a small travel stipend for our surgical team members on missions we hope to get going again next year. When donated surgical products don't meet the needs of our mission partners, we purchase them. And as we continue to grow, including the tremendous success of our chapter program with over 20 chapters in the first year, we can no longer be run entirely by people with day jobs. So we're looking for our first executive director to take us to the next level. That's why we need your support. So thank you to those who have donated in the past, those who will be donating today, and those who will donate in the future. We need it. Thank you.
Just as a reminder, I think that there also, all of us are volunteer. None of us get any paid for the work that we put on this on behalf of the organization, our students or chapters, or overhead. I think that the only capital that we have spent over the years is a small amount of money, also through a generous support of JJ and Ryan for our webpage, which I think is coming amazing and is doing great work around the world. But everything else, we just do it. As I'm doing with this, just like Kee, I'm just doing my own tweets, which I was pushed by Paola and Mike to be able to do better, and stuff like that. So in a lot of our patients, supporters, a lot of the patients around the world, they donate. Some of us, they do our own speaking engagements, and somehow we are able to connect back to Mission Brain. So we thank you all, and also for donating your time. I just want to make sure. And I am reminding of the very first time that I went with Will Aarsheim to Mexico in 2011. After we decided that we were going to do a first trip, we crossed the border, and in our way back from Mexico, we got pulled over because it turns out that the machine, told us that Will's was hiding something in his lower extremities. And people don't understand, he's an ultra marathoner. And literally the density of his calves is so intense that they thought he was hiding something metal-wise. And it was really that he does these 100-milers. He just recently did a 100-miler or 40-miler raise to be able to raise funds for Mission Brain and stuff like that. But that is the story with him. So we've been so blessed to have him and Lisa and April and so many of our supporters helping us. So good. Alrighty, April, what's next? Because we do have Devi at 9:30 Pacific time, he's stuck. So we have a few minutes, all right?
Right, we do. And some of you have already answered our first word cloud, so we would like to present the result of that. The second word cloud was also posted on chat, so I would encourage everyone to please participate on that one. It'd be interesting to see just what everyone is thinking about when they have these phrases in their heads or when they're talking about it. Also, I don't know if Antonio can join us. We have a few other questions here that I think we'd like to ask our panelists and our speakers. One of them, I actually would like to ask Dr. Park, and first and foremost, before I go into the question, Alfred and I, we've been talking about also making our scholarships available for research grants towards your efforts. I think this is one way that Mission Brain can participate and can actually be an effective partner towards those efforts. And in that, on that note, this is my question: how can Mission Brain, and this goes out to everyone, how can we improve what we're doing, and how can we be better partners in the effort towards health equity and global neurosurgery?
Oh, where do I start? First of all, let me thank you for that generous, the inclusion of, the fellowship to be eligible for people who aren't just coming to do clinical work, right? Basically what you're saying, research, advocacy, policy work could also be included in for these fellowships, and so many ways. So if you are actually working with a host country, you have actual clinical activities, start collecting data. That's where you start with research and see the impact that you're having. Is what you're doing making a difference? Maybe we can take that research and then use it for advocacy purposes. The other thing is supporting the overall educational aspects of global neurosurgery, not only clinical, like as you're doing, the research policy and those kind of things. And then I think for Mission Brain, with your high profile people within the leadership, there's a tremendous potential how you can change the profession of neurosurgery, how they think. You'd be surprised. I've spoken to very, officers of these massive organizations and say, we're talking about global neurosurgery. We're already global. They come to our meetings, we go to their meetings. They don't get it. There's a certain amount of, I don't want to, let's say, not ignorance, but really they haven't had the chance to really understand the big picture. I think once they see it, they'll be like, why haven't we done this before? So we need people like, the leadership of Mission Brain really to, educate the top organizations. Once they come on board, I think we're going to be in great shape. But yeah, that's just a start. A few things we can do together.
Great, thank you so much. Any other thoughts from our partners in other countries? And from Ernest?
Yeah, I was thinking about, I'm going to reinforce, I have a lot of thoughts, April, but I think Kee's last point is a critical one. So I would say if Mission Brain were to advocate on behalf of the global neurosurgery movement with people who are your peers, Dr. Lawton and Dr. Q, I think that would immediately transform the global neurosurgery space in so many ways. It wasn't too long ago. I mean, I am not even into my attending life. And I remember as a medical student being told that if you're going to do global health, you should go into family medicine or emergency. And why are you so interested in global health and you're going into neurosurgery? Thankfully, the common sense of, well, there's people in those countries that need better water and sanitation, everything. There's people with neurosurgical diseases too in those places, and what happens to them. And their lives don't matter any less than any other life. and yet there's no one there to take care of them. So, I was fortunate enough that that was common sense to me, and then struck with realizing that that actually was not common sense globally, certainly not in the high income country realm. So being an ambassador of global neurosurgery, beginning with your colleagues, I think would make a tremendous difference. I also think that partnering with colleagues who do get it to sort of amplify the message, like Bob Dempsey and FEAMS, right? And some of the people who are probably in those 3 programs from Raleigh's article, where there's a high level of global neurosurgery engagement. They're not hard to find, right? Like everybody in the space kind of knows, well, yeah, sure, Duke, of course, but they're an exception to the rule. Partnering with them to see where you could help to sort of expand the message. And that might look like doing things at grand rounds, seeing where there might be support to initiate a global neurosurgery program at an institution where that doesn't already exist. Looking at, is there a need in terms of mentorship, building bridges? Looking at how are we doing in terms of creating the space for global neurosurgery at our organized neurosurgery conferences? Can we do better? Does it make sense for a global neurosurgery dinner to cost $300 to attend? Things like this. I mean, I just think there's so much space where your leadership, certainly as an organization, and given the luminaries who run your organization, that you are, it's I mean, it sort of chills down my spine thinking about how transformative your influence can be in a very, very rapid period of time.
Great, thanks so much, Ernest. Now, I'd also like to ask either Ron or Gap, just because we've also worked with you guys in the past and we keep on working with you. So how can Mission Brain be a better partner in the Philippines?
Well, first of all, I don't think I've publicly thanked Mission Brain. So let me take this opportunity to thank Michael and April and Alfredo, and of course, Dr. Berger, who comes with us every now and then. And just to, I think, just to move forward from where we are now, the next part will really be to share it with other hospitals in the Philippines. So we have just started mapping out the manpower complement of the Philippines, and Ron is the author of that paper. And I think the next step is really to identify hospitals, which we connect with the Philippine General Hospital, to who will also benefit the same way we did in the last 4 or 5 that we've had Mission Brain activities in the hospital. So it's time to expand. I think that's the next step for us, for Mission Brain in the Philippines.
Thanks, Gab. Ron, would you like to add something?
I think I would have to go back to the principles of my medical school, the University of the Philippines, which has always been about community-oriented medical education. I think with these global neurosurgery partnerships, it is always important that if you want to implement projects, it should be for the people and by the people. So which means if, for example, you want to do a project, if you think there's a project that will be beneficial in a country that you'd like to partner with, you have to ask yourself, do the people feel that it's really important for them? Or is it something that you think is important for them? There's a big difference in that. And if you want something that will be sustainable, that will have long-term impact, and the people who would benefit from it should feel that they should feel that they have a big role in its success, from implementation to planning, from planning to implementation until evaluation. I think that's it.
Thank you so much. Yeah, it's extremely important to involve our stakeholders and really seek out their input towards this, because it is their communities after all. And on that note, I will pass it on to Dr. Garcia and Dr. Alba, who we've been working in your countries as well. How do you foresee us working in your countries more effectively?
Thank you. Okay, Dr. Alexandra, do you want to comment something before? First woman in Mexico, okay?
Everywhere, everywhere. So I think it's really important to work as a team. Our differences make us stronger. So whatever we can learn from each other, it will help a lot. So from one of the talks I heard that it was needed to hear what the needs were. So the needs here in Mexico are the knowledge. We do not have enough neurosurgeons who are teachers, who want to teach, who want to involve the rest of the medical partners. So that part is really helping us to involve the rest of the specialties.
Thank you. Yes, agree with Dr. Alexandra. I think that the knowledge is some of the most important thing that we can share. And I remember when, maybe 2 years ago, when Alfredo came to, we had the immersion brain here, I remember that he said, Victor, we need to teach to all these people how they can help, because they want to help, but they don't know how to help us. And you know, we are neurosurgeons, neurologists, anesthesiologists, but we are not used to have funds. We are not used to be in social media. We are not used to ask for help to someone else. So I think that when we see how other people can do this bigger and stronger, we learn a lot. And when we know how do you do in your places and share the knowledge, because I know sometimes people is envy about this, so people doesn't know how to do this. So I think that learning how to work together, as Alexandra said before, this difference will make us be stronger. And we want to have like simulation and to share the knowledge in virtual, not only in presential, and how to deal with non-profit foundations. And I think that's the knowledge, because we have a lot of people and students who wants to do the difference, but we have a lot of patients and how to deal with the government. And Dr. Park said before, and I know that there are people who wants to. Now we are involved more with universities, with hospitals, public and private hospitals. But I think that working together and learning not only about medicine, but about all the environment around us will be great for us.
Thank you so much. So those are really very useful and helpful input. And I would like to say that it's really been eye-opening to have everyone sort of come together, and it's inspiring to have everyone come together and have all their different points of view. I think we have one more question. Antonio has a representative because he's having a difficult time connecting. So someone else is going to ask the question for him.
I think we're gonna have Adrian Safa, also from his university, from Humanitas in Milan in Italy. Adrian, do you want to come in? There you go. I see Adrian. Let's see if you can. Go ahead, Adrian. Take it away.
Yes. Do you hear me?
Yes, we hear you very well, Adrian. Thank you.
Thank you. Thank you so much. Yeah, my name is Adrian Saffa, and I'm a member of the Humanitas Mission Brain chapter in Milan, Italy. So I'm a fifth-year medical student. Thank you so much, firstly, because it was an amazing discussion, really very inspiring talks, and I mean, to promote the global neurosurgery around the world. And really, we are trying to take as an example what you're doing. And yeah, actually, I'm very sorry that Antonio, who is actually a third-year medical student here at Humanitas, he just joined our program. He's really, I mean, motivated and passionate, and he didn't have the chance to ask the question. And he's working currently in our chair of research at Humanitas. So the question I will try to read, that I hope actually that I mean it is I transmit the same value that he wanted to give. He was like actually saying that when programming a mission, I mean, how should a global neurosurgeon prioritize between her own direct intervention on the patient versus the training of the local community? So he was saying that I can imagine that maximizing training would be a more robust solution in long term. However, in the most critical countries, which are the greatest challenge that the surgeons faces in training the community? So do you think that broadening the mission team's multidisciplinary could solve any of this? This was the question, so that Antonio wanted to ask to all the panelists in this case.
Maybe Ernest or Kee, maybe Ernest, you can start by taking this, and then we pivot to Kee and see what their thoughts are.
Sure. Yeah, I'd be happy
Thank
to.
you.
Thanks, Dr. Q. Yeah, what a great question. So the short answer is we need to do both. We do need to do both. Now, as I said at the end of my talk, listening and building relationships are the critical first step. And actually, that step is our best first opportunity to minimize the impact of or avoid the trap of coloniality that Ron Baticulon spoke about. You know, so showing up not with some preconceived notion that you know, I am better than whatever is going on here, and so these people are lucky that I have shown up. You know, which is often what's done. If it's not done explicitly, it's done implicitly through actions. We don't even realize it because it's sort of cooked into our behavior. And you know, a way out of that is to have the cultural humility to take a step back and realize, first of all, I have no idea what's going on in this environment. This is not what I'm used to. I need to make some friends and really listen to what they have to say. Now, if they're telling you that there's a critical need to provide care, and whether you're in country actually as a neurosurgeon making this determination, or you are a visiting neurosurgeon making this determination, well, you've got to look and see, well, what makes sense, what resources are available to you. Can we start to do some of that providing care right now? And can we build into that providing care the beginning of what can ultimately become a training program? And this was actually what Mike Haglin's approach ended up looking like in Uganda. So that's one way. There are many. And so, you know, I'll pause there, but a great question. It's not either or, both are important.
Kee?
Yeah, great question. I agree with Ernest. You know, there's these countries with really little or no neurosurgeons. If the idea is that we want to try to get these countries to think about scaling up neurosurgical service in a nationwide way, you really have to have someone inside that who's going to drive it. You know, we provide advisory services, but we really can't jump into a country and say, here's what you need and here's how you should do it. So you really do have to have a broad stakeholder engagement process at the beginning. And who are the main drivers of this? Let's say in Sudan or Afghanistan, and we facilitate those meetings, right? But at the end of the day, once you identify a champion or group of champions, it's what you all do: empower them. We got to have them, you know, help them, finance them, provide them with extra staff. Otherwise, they lose steam. And you all know this. If they're neurosurgeons, they're way too busy providing services, right? If they're already short neurosurgeons in these countries, they work from 7 to 7 in a government hospital, may see a private patient in the evening just to supplement their income. I saw this in Vietnam, in Cambodia, and Ethiopia. So how do you empower these champions so that, give them sufficient support so they can continue to work with the ministries of health in driving these things forward?
Beautiful, Key. And I think that there's a comment right there that Muhammad just put. You are there to serve, not to save people. And I think this is a very important. I'm gonna just do one more comment, then we're gonna go to April to show something. But the very first mission that we did in Mexico, and Rodrigo is not here, but Victor was part of that. We were scheduled, it was 2011, and I had been going to Mexico already since 2005, published a couple of textbooks and whatever, doing a lot of education, and nothing where we were gonna go and do surgery. And it was really Mike Lawton's idea that we go and do some surgery in some parts of the world together, especially in Mexico. But we had it all set up in a hospital. And at the last minute, the night before, we were already in the hotel, in a small little hotel, we were all together. They decided that they were going to close the doors. And they had no idea, because they didn't know that I was Mexican. They just saw this guy with a hyphenated name, Harvard educated. They didn't know that I grew up in a very poor family in Mexico. So they had no idea who I was. And they went on to close the doors, and we had to pivot into a different experience. And now the doors are being opened, and Victor is going like this, because that's exactly what happened. Because we were not there to tell people what to do, which is the colonialism. I mean, I grew up in Mexico being poor, and I remember, Americans, leave, go, don't come and tell us what to do. And I think that these are the kind of things that we have to get rid of. We have to, get rid of those barriers and change the way we are there, as Mohammed said, to help people, to serve people. We're not there to save anybody. Our own countries, they have to do the saving. Our own people have to do the saving. From us here, we build bridges. So, April, take it away.
Thank you so much. So I think we have our first result from our first word cloud here, if Ryan could share that. And that was the question: what words do you associate with health and social media? And then we have universal health access. Equity was the biggest one. So it's really interesting, because right now, one of the things that I think we've all talked about is how, because of the pandemic, we've learned to really live a good portion of our lives virtually. And we've found both benefits and disadvantages to this. And I think this webinar is actually one of the big advantages that we've found, especially with Mission Brain. We haven't been able to travel, and we've found that there are a lot of other ways that we can actually be of service, and we can actually contribute to the conversation in this manner. And Ryan, we have the second word cloud result: health equity. So one of the big ones is empowerment. I think it's very important, and it's global, and empathy is another big word there. I also encourage anyone to just jump in if you have any comments about the results for our word clouds here. This is from our participants today. And those are the two. I will keep going with one more word cloud, but we're gonna go ahead and start our next talk with Dr. Devi Shetty, and he will be introduced by Paola Meade.
All right. Can you see my screen?
I see your screen. Can I make a comment about Paola, Mike, and Andres, Key, and Ernest, and everybody? They are full-time in the laboratories. They publish some of the most amazing papers in science and clinical. Actually, they got multiple awards. All this work is volunteer. They work in nights and weekends, to coordinate. Their full-time is in the laboratory. I mean, Paola is leading 2 major multi-million-dollar grants that I have from the NIH right now. And so is Andres, and so is Mike, and innovation, patents, things like that. So this is all volunteers. I just want to make sure they put all these slides for you, because they are so grateful that you guys are here with us. All righty, take it away, Paola, please.
Thank you, boss. And we're happy to help. Mission Brain is our special project. So I want to introduce Dr. Devi Shetty. Dr. Devi Shetty is a cardiac surgeon of repute and successful entrepreneurship. He is highly respected for his ingenious ideas to reform the healthcare sector in India. His visionary leadership to make quality healthcare affordable for all has drawn global recognition. Treading the path of economies of scale to bring down the cost of healthcare delivery in India. In association with the government of Karnataka, Dr. Shetty pioneered Jeshawini, a very inexpensive microhealth insurance scheme benefiting more than 3.4 million people. He is the current chairman, Board of Governance, Indian Institute Management of Bangalore. He has also served as a member of the Board of Governors of Medical Council of India and representative of President of India in the Board of Governors of Indira Gandhi National Open University. He was
And
part of the
Paola,
national, yes.
Were you meant for us to see slides? Because we
Yes.
are only in the first slide. I don't know if you meant for us to see pictures or slides or anything else like the other speakers.
Did, sorry. Is this good now?
You're sort of in a different style. You're like maybe in the last presentation or something.
You're in presenter mode.
I'm in presenter mode, sorry. Is it good? No. No,
Change the view, just display settings. There you go.
good, perfect. So just to finish, Dr. Devi Shetty was also featured in the Netflix series The Surgeon's Got as the main character for the last episode for all the work that he does in India. So welcome, Dr. Shetty.
Hi, my name is Dr. Devi Shetty. I'm a heart surgeon by profession, and technology is very close to my heart. I'm extremely grateful to the organizers for giving me this opportunity to interact with you. COVID has turned our world upside down. Everything what we are going to do in the future will be done dramatically different than how we did it in the past. 100 years from now, if someone is going to write the history and evolution of society, there will be two distinct periods. The period before COVID will be BC, and after COVID will be AC, that is after COVID. One of the industry which will undergo dramatic transformation for good is going to be healthcare industry. Why do we need to disrupt the healthcare industry? We need to disrupt the healthcare industry because it is the largest industry in the world. Global healthcare and wellness industry is a 8.5 or 8.6 trillion dollar industry. We are spending today more money on healthcare than buying the food, because agro industry is only about 8.2 trillion dollars. Everyone thinks automobile is a big industry. Automobile is $2 trillion. IT is only $3.4 trillion. Oil and natural gas is $2 trillion. They are nothing compared to healthcare industry. The quantum of money spent on keeping ourselves healthy. But after spending $8.56 trillion, not more than 20% of the world's population has access to quality, affordable healthcare. This is a pity. Now, current situation cannot go on. People are going to demand better healthcare. If we have to one day decide that let at least half the world's population have access to secondary and tertiary level healthcare, we need to spend more than 16-17 trillion dollars, which do not exist. Then how do we address? The only way we can address is by digitizing healthcare. Digitization of healthcare will make it safer for the patients. It will make accessible to the patient. Now let's talk about safety of healthcare. Everyone thinks that hospitals are safe places for the patients. I'm sorry, we all know it is not the safest place. American hospitals are perhaps some of the safest hospitals on the planet. If 200 patients get admitted to an American hospital and spend just one night, 1 in 200 dies due to medical error. Not medical negligence, medical error. Getting admitted to an American hospital is 10 times riskier than skydiving. Why hospitals are not safe places for the patients? Hospitals are not safe for the patients because every doctor has his own style of treating patients. In the process, even though there are protocols and SOPs for treating the patients, that really in reality doesn't get translated. In the process, when we admit our patients to a hospital or when we want to choose a hospital, we always want to know some details about the doctor who's going to treat our patients. Whereas when we board a plane, we never ask what is the experience of the pilot is or who the pilot is. Because irrespective of the seniority and the experience of the pilot, he can take off, cruise and land in the same manner. Pilot cannot have his own style of flying the plane. In that case, the planes will land all over the place. But that hasn't happened in healthcare. That hasn't happened because even though there are protocols, it couldn't be implemented because these protocols are written and that's in a thick bound file which is kept inside the cupboard. And the other reason which Joint Commission attributes for the medical error is the communication failure. 65% of the sentinel events happening in the hospital, which generally leads to mortality, is due to communication failure. And communication failure happens because most of the electronic medical records which are used today, they are built for the laptops. They are not built on a mobile platform. Unfortunately, doctors look at the laptops or a desktop maybe 5 to 6 times in a day. But doctors look at the mobile phone 200 times in a day. If the entire electronic medical records are shifted from the laptop, desktop to the mobile phone, with the concept of mobile first, dramatic changes can happen. And this is what happened in every industry. The moment the service was accessed on a mobile phone, utilization of the service started getting increasing by leaps and bounds. And in the process, when there is any abnormality in the blood test or a clinical picture of the patient, doctors will get to know real time. I am convinced that in the near future, maybe in 4 years, 5 years, smart software will make smarter diagnosis than doctors. And within 5-7 years' time, it will become legally mandatory for the doctors to get the second opinion from the software before starting the treatment. I know it is going to happen much before. I'm just giving this long gap of 5 years, 7 years, so that my professional colleagues will not shoot me down. Technology is already available today. If doctors cooperate with the software engineers, they can make amazing software to give us a differential diagnosis based on the experience of some of the top doctors in the world. Sitting in our clinic, we can have it. But it is too far-fetched for a software engineer to sell this concept. The greatest impact of digital disruption of healthcare is going to be that every patient will consult the medical specialist, starting from headache to heart attack or any problem, first time online. This is going to happen, and that will have a massive impact on the outcome. Today, patients with any health issues seek medical attention very late in the stage of the disease, because experience of going to a hospital and seeing a doctor is horrible. It is not a pleasant experience at all. If the same patient can see the doctors online in his mobile phone, sitting at the comfort of his bedroom, believe me, for everything, they will consult the doctors without any delay. And those doctors who say that I am not going to see patients online, they have to come to my clinic, believe me, within the next 1 or 2 years, they may not have patients to see them. In India, 30% of the cancers are head and neck cancers. Yes, a patient, because we have a very high tobacco chewing habits or smoking habits. Let's look at a cancer of the tongue. It's a painless ulcer at the tip of the tongue. And it doesn't bother the patient. They don't want to go to the hassle of going to the hospital. It's just that it doesn't heal. Once patients are comfortable to see the doctors online, all the patient has to do is to put the tongue out and show the doctor the ulcer. And any doctor, even a junior most doctor, will know one look at the ulcer that it is not a simple ulcer. It requires a biopsy to rule out cancer. And if we can detect cancer at an early stage, a simple operation costing few $100s in my part of the country can save the life. But the same patient comes to see the doctors with a big ulcer, virtually half the tongue is gone, with a big lymph node in the neck. Even if you spend millions of dollars, you can't save them. So we believe that online consultation, because of the comfort, patients will consult the doctors at a very early stage. Another area which will get dramatically disrupted is the critical care services. We believe in the next 5 to 10 years' time, almost 80% of the hospital beds will be critical care beds, because whatever you are doing in the room or the ward in a hospital will be done at home. The problem is a massive increase in the critical care unit will be very difficult to run, because a patient in the US, India, or in Europe, in the ICU, critically ill patient, gets the best care only 8 hours in a day between 9 to 5 when all the senior intensivists are present. For 16 hours in a day, patient in India or in US or Europe gets suboptimal care, cared by junior doctors and junior nurses. This is going to change. This is going to change when the entire data of the patient is available on a mobile platform and the doctors can see those data sitting at home, see the patient on their screen, talk to the nurses, talk to the doctors present. So if you have a 50-bed ICU, you just need maybe 4 or 5 anesthetists who can ventilate, adjust the ventilator, put the central line, or put a ECMO or intra-aortic balloon pump or whatever. Only people with the skill who have to do that procedure will be there, not more than 5 to 7 people. All the thinking doctors who anticipate what is going to happen to the patient are going to be at home taking care of the patient for 16 hours. But they're not going to work for 16 hours. The 16 hours will be split into 4-hour slots. So every intensivist, irrespective of the age, will be happy to work at night just for 4 hours, maybe once or twice a week. And during that 4 hours, they only manage maybe 10, 20 patients. They have all the data with analytic tool, which will constantly tell them what is the chances of this patient developing a cardiac arrest in the next 10 hours or 12 hours of 24 hours with all the data. And believe me, that will increase a pool of intensivists who can offer the services, as well as the job satisfaction by the intensivist. And more than anything else, intensive care service will become proactive, not reactive. When that happens, cardiac arrest in the ICU will go down dramatically. And when it is going to happen, all the doctors will be standing near the bedside anticipating that to happen, which may be inevitable in some patients. So that will dramatically reduce the mortality, morbidity in the hospital. In the end, my observation and the prediction for the future is that Uber, world's largest transport agency, doesn't own any vehicles. Airbnb, world's largest hotel room provider, owns no hotels. Alibaba, world's largest retailer, has no inventory. And largest healthcare on the planet will have no beds. It is going to be a software. And welcome to the disruptive healthcare, which is going to make our world a better place to live. Thank you very much for the opportunity.
Amazing talk by Dr. Shetty. Honestly, he was unable to join us in person, but he did answer some questions that we had and that we've been communicating. He's been traveling. I mean, he's just truly a visionary, and I know that he's been very innovative in India and throughout the world, and extraordinarily well known in this field. It's interesting, at the end he ended up with Uber and Airbnb, and I actually had comments exactly like that as I was reflecting on this discussion of over $8 trillion that we're spending in healthcare in the world, and that's actually half of what we really need. But the reality is probably that's not going to be enough. We spend $16, $17 trillion. That is higher than the car industry, than any other industry. We spend more on healthcare than food. I mean, you just think about this amazing amount of needs that we have in the world. Our healthcare is gotten so expensive, you know. So can we replicate what is happening with Airbnb, with Uber, and healthcare? Can we create in the future with our young minds wireless technology to monitor patients, you know, and monitor them at home? And that way they don't have to be in the hospital as we're looking at their potential risk of having a seizure after a craniotomy for brain tumor through wireless technology. Can we use artificial intelligence to analyze the results of their wireless technology, disconnected the technology, and predict when the patients may need to go in for much, much higher level of care? So basically what we are doing potentially is going back to the future, because if you guys remember when hospitals were funded in the world, in the United States, the Mass General being one of the earliest hospitals that were funded, there were places where people went that were extraordinarily sick, right? Everybody else was getting care at home. Doctors would go and visit you at home. Now we can visit you through technology, be there at the moment. And I think there's some healthcare organizations that are certainly doing that. I have the privilege of working at Mayo, where I sit on the board, and it's exactly what we're doing and what we're moving into the future. So we're going back to be able to take care of patients in the future. And I think that these are where our young minds, where we have a lot of chapters around the world, they're going to have to become innovative and creative for us to be able to, you know, to get better care at a much more affordable price. Otherwise, we just won't be able to sustain our future generations. So we had a few minutes for some comments right here. I'd be interested to hear from Dr. Legaspi or Ron, actually, since you just turned your camera. Would you like to comment as to how the sort of things that you guys are doing in the Philippines to, just like what Dr. Devi Shetty is doing in India and other parts of the world, what kind of things do you think are going on in the Philippines that are going to allow us to move to the next level?
I think the important word here is disrupt. So we need to be pushing boundaries and disrupting the status quo, because if we maintain the status quo, it will be impossible really to achieve what we want to achieve. I think the reason why we have the status quo is because the people who are in power and are making decisions benefit from that status quo. And that's why it's important for us to disrupt, to think outside of the box, to get outside our comfort zones. And health is, it's not just being in the hospital. If you want, for example, if you're a neurosurgeon, you will be able to help one patient at a time when you're in the operating room. But if you start with the systems thinking, then you will be able to help a lot more, and that ensures continuity of care for future generations. So I think, for example, when you look at the Philippine healthcare system, so at the moment we are still moving towards universal health care. So at the moment, there's still a great divide between public patients and private patients, and the disparity in care is really staggering. I think, reflecting on my experiences, having worked, for example, in Australia, so I worked for a year as a fellow in Australia, where we never had to worry about whether we had money to pay for a CT scan or an MRI. We just got it, and we just thought about how we give the best possible care for this patient I have in front of me. But now, having gone back home in the last 4 years, every time I see a patient, it really pains me, because one of the first few questions I would have to ask their families is, so how much money have you got? Would you be able to afford getting admitted in a private hospital? Or would you have no choice but to get admitted in a public hospital? And if we really want to be able to provide equitable surgical care to all patients who need them, then we need to be disrupting a lot of barriers. And that means you have to work, whether you like it or not, you would have to work with the politicians, the stakeholders. You have to do lobbying, and you have to work, for example, with policies. So at the moment, we still don't have folate fortification, even though we have a very high incidence of spina bifida. Folate fortification is facing a lot of resistance, and it's crazy. and motorcycle laws are not being strictly enforced, so we still deal with a lot of motorcycle TBI. So it's that sort of thing. So I think my takeaway from the last talk is really disrupt. We need to disrupt, and we need to stay out of our comfort zone. We need to push and fight for our patients.
Beautiful comments, Ron. And I'm going to pivot right now to Kee, and I'm actually getting some comments also in the chat by Maria, one of our extraordinarily supporters from Madrid, Spain. I'm going to see if we can push her up to make some comments. But Kee, Dr. Park, you want to make some comments about this? Because the concern is, from the public, and this is what Maria is alluding to, is that they still want the personal contact with the physician, with the doctor, with the surgeon. So how do we provide that and get used technology and not have patients be in the hospital where the cost is exorbitant, and also where the mistakes can be unfortunately made errors?
Wow, no, great questions. Yeah, I have an appointment next Wednesday with my gastroenterologist. It's all tele consult. It's really to just book my next endoscopy, right? So why do I have to go into the hospital, park my car, and all that stuff? It's so easy. I think telemedicine is really proven itself during the pandemic, and I don't want to see my doctor. Yeah, not for this. Now, there are times where I do need to see him, but this is not one of them. But I want to go back to what Ron really talked about the folic acid fortification, why that's important from a global surgery standpoint, global neurosurgery standpoint. We tend to think about the gaps in surgical care and then think about inputs, right? Meeting the building capacity to meet the demand. But the other way to look at it is to reduce the demands themselves. So for instance, we can reduce head injuries from road traffic injuries from safer roads. There's a lot of prevention things that can do that can reduce the demands on the health system, the surgical system. That works just as well. That it should be a comprehensive approach. So for spina bifida, we know we have class 1 evidence that folic acid fortification can prevent 90% of spina bifida cases in the LMICs, but it's not being implemented. So there's a large group of people, Jeff Blount and a number of Ethiopians. And this is a huge group, pediatricians, former CDC officials that are trying to get a global fortification for folic acid. The Ethiopians have beautifully shown within their country the burden of spina bifida at the rate of their the increase of neurosurgeons as quickly as they are going. They won't meet the burden, the number of surgeons, until 2038. But if they reduce the spina bifida burden by 90%, they'll at least meet that burden within the next 7 or 8 years. So you see the difference. We have to think about it, not just from a surgical standpoint, but prevention, use all tools available to us to meet the demand for surgical care.
Yesterday, I was in the, 2 days ago, I was in the OR with one of my friends who is an innovator. We belong to an academy at Mayo, and he was telling me this new device that they're testing, in the hospital, in which the rooms are digitally sort of equipped in such a way that the patients are completely 100% disconnected. They have no wires, nothing. And it's all based on technology that the government and many military agencies use to be able to monitor heart rate, temperature, even how much you sleep, your sleeping rhythms, everything that you can possibly imagine. So that way you are connected. And I think that what is that allowing us to do, and that all that information is being pushed to a central computer where you're using artificial intelligence to begin to monitor this. And I think that this is where potentially, even though it would require some level of investment, our challenge is going to be, how do we design new technologies that are less expensive, and that way it would allow us to provide better care for our patients. And then when they need the surgical care for trauma, brain surgeries, shunts, whatever we need to do, we can spend that money in providing those thousands of surgeries that are needed every year. So somehow we'd be able to, do better with the resources that we have and the way that we provide medical care. But I think that that's something that we need to be thinking about, and I hope our young minds are thinking about it. So thank you.
Alfredo, maybe I just add a quick comment.
Please. Yes.
Ron also talked about the 3 delays, right? The first one is the seeking care, right? Patients aren't even aware that they have a problem. And mobile technology can sort of make that gap go away, right? Because I get reminders, right, all the time. It's time for your checkup for this, checkup for that. And so are you having these symptoms? So I think that could also revolutionize, this and shorten that gap of seeking care.
Beautiful comments. Good. Well, we pivot back to April right here. How we doing with time, April? I think that we're keeping track, all right?
We're keeping track of time. It's really interesting. We've got about a couple of questions here that I'd like to have our audience ask our panelists regarding the topic that we just discussed. We're going back to Neha again. I think she's got a lot of lovely questions here, really interesting questions. Neha, if you could unmute yourself and ask your question, that'd be great.
Hello, nice to be back with everyone. My question to the panel today is, with sweeping changes in digitalization of healthcare, how do we make sure patient health privacy is not breached? Also, what are the steps that we can take to prevent people or multinational companies from misusing this data? Thank you.
I might jump in on that one.
Yes, please, because you've been thinking about it because of the global surgical endeavors that you're doing.
So at the World Health Summit in Berlin just a couple of weeks ago, this was a big topic: privacy, data privacy, right? And so when we move into this digital health arena, And so there's a framework that's being developed. And this is a whole new area. People have never thought about how to protect personal identifiable data. And because data is important from individual perspective, but from the big data standpoint, right? So I'm not an expert in it, but that is a very important topic, and they're actually dealing with it as we speak.
Beautiful.
Thank you, Dr.
Great
Park.
question, Neha. Thank you. And
Thank
I
you,
don't
Dr.
know if we can. Beautiful, Neha. Thank you. I don't know if we can move Maria up. She was there for a minute, and then I was going to ask her to comment. She began an organization in Spain that is also doing amazing work. Can you see Ryan or JJ if we can move Maria up? Maria, can you hear me?
Maria, if you
Let's
can
see.
unmute yourself, that'd be fantastic. I think you have the ability to do that.
Right. Could you hear me?
Maria.
Hi, can you hear
now,
me?
Maria. Yes, we hear you very well. Can you hear us?
Yes, perfectly well. Yes.
Beautiful, beautiful. Well, Maria, maybe we can ask. I mean, you're asking a question, and obviously you have your own experience as someone who is going around the world and trying to make sure that people understand that neurological brain disorders are real. Maybe I can ask a question. Your thoughts about the way in which medicine could move forward in the future through digital technology, and what are your potential reservations about that?
Well, I think obviously the more we develop, the more we study about technical parts and digital parts are amazing, but we cannot forget that we're humans. And from my point of view, as a patient, I really, I'm willing to see my neurosurgeon. I haven't seen him for like 2 years almost. And all the patients that I have in Brains Get Famous, who are quite a lot all over the world, are exactly complaining about the same thing. Of course, it's very nice to be in the sofa waiting for a phone call or just seeing someone through a computer, but we're humans. And we also need, your input. We are just taking care because of our intuitions. If someone doesn't see us, if a doctor don't see us, if they don't see how we move, how we talk, whatever, after a neurosurgery or after we have a brain tumor or any kind of injury in the brain, how the doctor is going to see through the machine if we are not talking. If we're not talking in front of them, if we are not walking in front of them, if we're not expressing in front of them. So there are many issues that machine cannot really see through. And I have, most of my family are doctors. My mom is a doctor. My grandfather was a doctor. My uncles are doctors. And the success of them is that they see people. They didn't stop seeing the people. They see the patients. It doesn't matter. Of course, with the pandemic, there were some restrictions, but I think the success is that they still see people because there are some areas with the brain that they're not, we cannot just follow our intuitions. Not even when a doctor is amazing. There is need some, like touch something. They need to see us. That's my opinion. Of course, the technology is amazing, but for other kind of things, technology to make wonderful surgeries, to improve, to make other things regarding to the machines that are operating us, but not from humans. We really need to be seen. That's my opinion, my humble opinion. And it's not just mine. I think I'm sharing with many other patients that we have in Brains Get Famous. We're not so little. We're a big family.
Beautiful, Maria. Thank you. Those are great comments. I think that illustrates the complexity. On one side, we want to provide more. On the other side, we still need to be in touch with the patient. I think that when you got a lot of nods right here from everybody, they continue to nod. I think everybody agrees with you. I think the question is going to be, how do we maximize technology to provide better care in many other disciplines, and yet the disciplines like neurosurgery, which is quite complex for all the reasons that you mentioned, to be able to do those 5,000 surgeries that are needed, this year alone, to be able to provide them, around the world, to be able to train more. So I think that what we do is potentially use technology for some disciplines where we can do it better. And maybe for some other disciplines like brain surgery, spine surgery, we're going to have to continue, to somehow make sure that we continue to have that personal touch with our patient. I think that that's what you beautifully illustrated as a patient, as someone who advocates through your own foundation. So we thank you for your comments. I think that you saw a lot of agreements right here. Gorgeous. All righty. I see April, take it away. I know that we're trying to stay on time, obviously.
We are, and we're doing pretty well. And we have one question from Udit. I hope I'm pronouncing your name correctly.
Yes.
If you could unmute yourself, please, and ask your question, that'd be great.
Thank you so much. Am I audible now?
Yes, you are, Udit. Thank you.
So that's great to be here. So I would first like to extend my warmest wishes to everyone. So my question is that, like Dr. Devi Shetty, I think in early 2015, he floated the idea of health cities. Now that is very evident in Cayman Islands around the US, and even in India, his healthcare setup, that is Narayana Foundation, is building health cities. Now the question arises that we just had a pandemic and it's still going on, it's still rising again. These health cities are much prone to become a health hotspot of these pandemics. How does this concept of integrated health cities fare well in a world full of pandemics and raging pandemics? Isn't it very controversial, and cannot it jeopardize the entire setups? How do we go about it?
I welcome any answers to that from anyone in the panel.
Beautiful question. I was going to ask to see if Ernest can, because I've really been thinking a lot because of his work, that he's doing also with global neurosurgery. Go ahead, Ernest.
Sure. It's unfortunate that Dr. Shetty is not here to answer directly, so I can only speculate. I still think, Udit, your question is an outstanding and timely and highly relevant one. There's no question that there's going to be an added risk in terms of pandemic risk in the health city technology. There is also an opportunity to mobilize vaccination and treatments, probably with an order of magnitude greater effectiveness. Where is the balance between having to scale back on the innovation in service of protecting the population versus figuring out how to best leverage it to mobilize our treatment and protective strategies? I'm not sure, and I think that'd be something great to have Dr. Shetty speak to. But these sorts of risks, I think, come part and parcel with any new and disruptive technology. And hopefully you'll have an opportunity to hear from Dr. Shetty himself about how he's dealing with it, because I'm sure, in fact, that Narayana is dealing with this right now.
Thank you, sir. Thank you so much for your response. Really appreciate it.
Beautiful.
Great. Do we have any other questions from anyone? Any other points of view? One of the things that I actually wanted to ask, if anyone wants to provide input for this, is how do you think digital technology can either potentially bridge the gap and promote health equity, and also at the same time widen that gap of inequity, considering that these are all very resource dependent innovations?
My impression, April, is that it's like anything in technology, there's going to be a price that we're going to have to reach, we're going to have to spend before we can see the benefits. I mean, as you can imagine, with all the things that we're talking about, wireless technology and things like that, and connecting the world, the reality is that there are many parts of the world that they don't have wireless technology, they don't have internet, they don't have this type of things. So we take it for granted in those places, those cities, those countries that they do, but we're going to have to invest on that, number one, and that's going to take a cost, it's going to take a toll, and that's going to take away from some other things, number one. Number two, once we do that and we can connect the world in a much more efficient way, we're going to have to invest in innovation. We're going to have to encourage our youth from all over the world, and now they're communicating differently, to create new things, invent new things, create new companies that will be more socially responsible. It doesn't have to, nowadays when we think about non-for-profit versus for-profit organizations, even for-profit organizations are very, very much leaning towards a social sort of equity and doing things that will benefit humanity. So you can still have, for-profit organizations that will use a lot of their profit, to be able to go back and invest and reinvest in creating new technologies that will be less expensive, that would allow us to connect. So that way we can take care of patients much better, anywhere, anytime. And doctors can come to the patient, as Maria said, because they need to be connected, where you can deploy, all the way from nurses to technologists, to therapies, where you can use technology already. In some parts of the world, Amazon is already delivering drugs, instead of patients having to drive or having to go. So there are a lot of things, I think, that are going to have to happen before we can achieve, a world in which anybody can have access to complex healthcare. But I think it's this next generation that is gonna, allow us. And I think that we're putting all the tools. This is what I think that what we're doing with Mission Brain, what we're doing with Haiti, with the organization, with Ernest, what we're doing with Mexico, the Philippines, anywhere in the world. And I hope that this will allow us to build those bridges that are necessary.
Great, fantastic, thank you. We have two more questions, so we're going to go to Shreya first, and if you could ask your question, Shreya, that'd be great.
Hi, so I just wanted to ask, everybody was talking about how we have to move to mobile phones. We have to move the electronic health record system onto the mobile phones from our laptops. But we are planning to serve Mission Brain in an area where people don't have access to smartphones. So how do we circumvent this problem? And it's not like we could go ahead and figure out funding to give everybody a smartphone, because that would be really expensive at this point. Is the only solution finding out an alternative device, or how do we do this?
Answers from anyone?
Sure, I'd like to address this. I think the last several questions are several aspects of a common theme. So so thank you for your question, Shreya, because in fact, I've been thinking about Haiti. So even in of course I have, but people in the Western Hemisphere tend to think of Haiti as the poorest country in the Western Hemisphere, and there's a reason why. For a long time, Haiti has been and effectively remains the only low-income country in the hemisphere, and yet a substantial percentage of the Haitian population does have access to WhatsApp. So that presents both an opportunity and a challenge. The opportunity, certainly, and this does not address your question. Your question I'll get to second. This addresses the equity conversation that April had brought up. Health equity, the perspective of global health equity is actually distinct from the perspective of public health. And this is really important. It's innovative to even think about health equity meaningfully, where public health tends to look at, what is the greatest number of people we can benefit at the least cost per beneficiary. It's not necessarily a no one left behind approach. It's the greatest possible good for the greatest number approach, which may not match perfectly our goals in health equity. In health equity, as Ron said earlier, it's where is the greatest unmet need, right? Who is suffering the most? And what can we do to bring our greatest service to the people who are suffering the most? And I think that's a piece of what you're talking about with the access to a mobile phone. So I mean, there are a few different components. I attended a talk several years ago at MIT with an individual named Dr. Dinesh Pendarkar. He's a fairly well-known illustrious oncologist, if I'm not mistaken, in India. And he did some tremendous work innovating using WhatsApp for cancer care in India. And I think there were a lot of lessons in what he's been able to do. But you know, when you consider Maria's call for making sure we don't lose the touch of the physician, I think it's important to also think about what are our workforce limitations? What are the concerns in terms of the workforce available, not just for neurosurgical care, but all aspects of healthcare? And what innovations are there? Human innovations are there for dealing with workforce. And there's a conversation about task sharing and task shifting in neurosurgery, which is how do we extend and expand the skill set of a neurosurgeon or neurosurgical capacity to people who may not be neurosurgeons or weren't traditionally thought of as neurosurgeons, but can play a vital role in helping us to address that human aspect. The community health worker model has been a very, very powerful one across disease entities. And Partners in Health has done great work with this in Haiti. And it's one we should look at because, for instance, let's say you can't get a mobile phone into someone's hand. By the way, you should talk to any of your local phone companies and see whether that's even a possibility, and really bring that conversation to the forefront of a country's national healthcare system. So I don't think that it's as easy as accepting that you can't get a mobile phone into everyone's hand, especially in the current global economy. So that's an important step. Talk to the local phone company who is providing people with that technology. But if that doesn't exist, perhaps what you're looking at is building a workforce that is supported by or supported with that kind of technology. And that workforce certainly either has or identifies the resources to be supported by technology. So now this is a marriage between both the mobile phone and using the expanded human workforce. So you might have some kind of a neurosurgical officer, if it makes sense for your country's context, who's going to go and examine a patient who doesn't have a cell phone, but has been trained in doing this critical neurological or neurosurgical assessment, neurological evaluation, and takes some pictures, right? Because the patient has a clear deficit that might be attributable to some list of diagnoses. And then that health officer is communicating with the neurosurgeon, helping the neurosurgeon to figure out, what do we need to do and what do we need to make available to this individual who doesn't have the kind of access that the more privileged components of the population do. And we can go further. So there definitely are health systems level innovations that can solve this problem. And I think they're a very important part of how we look at this. The last thing I'll say is when we innovate, the very idea of disruptive innovation must begin with this concept of health equity behind it. So it's not only, what do people have already that we can use? It's who is suffering the most and what do we do to provide care to the people who are suffering the most? And that's really the first step in my mind, because I think you innovate in a different direction when you begin your innovation with the advocacy of the destitute sick.
Beautiful comments.
Thank
Beautiful.
you. Thank you.
April getting ready to summarize. Go ahead, April.
Yes, we have, I just want to add that there's a difference, and it's a sort of lovely way of describing the difference between equality and equity. One of my professors had this slide that I just wanted to share really quickly. It's about the analogy of a service, for example, like if someone needs if a community needs a bicycle, you don't just give everyone, young, old, disabled, the same kind of bike. You have to find a bike that fits a child, for example, or a bike for someone who's a lot taller, or a bicycle that is accommodates the handicap of the person. So we have to think of equity in that manner. I will have Udit has a bunch of questions here, but I will have him probably send it to us at one point, and then we will have some of our experts answer those questions at a future time. But these are great questions, and we don't want him to feel like we haven't addressed his questions. So on that note, I will hand it over to you, Q, to give us our closing remarks.
Thank you, April. I was just thinking about the question from Udit and the questions from Chure, and I'm just going to put it back. We need you to innovate. We need you to think creatively. We need you to build bridges. This is what the whole idea of Mission Brain, the chapters, ideas such as the hackathon, where the students at Harvard and India and Mexico, they're putting together events and they're connecting the rest of the world. We need you to be creative. We need to be innovative. If it's the mobile technology is a limitation, just get around it. Use what cerebrospinal fluid does, which is moves around limitations and figures out the way to go from one compartment to the other. I think that at the end of the day, you have to be able to feed at any given point your hope. You have to feed the hope that you can change the world. In any sense of doubt, you have to starve that to death. You can never doubt that you can change the world. And sometimes it takes great amount of work, sometimes it takes great amount of sacrifice, and sometimes you realize that before you can be good at something, you're gonna have to be bad at it, and you're gonna fail miserable. And I go back to what Dr. Park said earlier, which was a quote from Rosa Parks. We only fail when we fail to try. We only fail when we fail to try. And none of us are failing at trying right now. So we are being successful. So I thank you all for your extraordinary efforts, for bringing us together, for being part of this. We look forward to many, many more things. Next year, 2022, we'll plan to do some trips, and hopefully the travel and restrictions will be much easier to overcome. So April, thank you.
Thank you, everybody. I really appreciate everyone being here, to all our volunteers, our students, our panelists, all our speakers. I know some of you have to stay up late, some of you had to wake up really early. And I am taking notes. Ron, we are definitely going to have a rotation in the time frame for the next time. So I appreciate everyone being here. Have a great day, and looking forward to more participation from everybody. Thank you so much. Have a great day.